Saglambani of the San Francisco Giants. And Dr. Keith Meister of the world champion Texas Rangers. Again, it's been my honor that we celebrate the Professional Baseball Athletic Trainers Society and 40 years of being around. And again, we appreciate all of you physicians, the Medical Advisory Committee, the Commissioner's Office for all the support that you provide for us and all our medical staffs. Thank you.
All right, congratulations to all the physicians for their 20-year service awards. And with that, I think we will get the program started. Steve, here he is. Okay, great. Steve Cohen's going to kick us off. Thanks very much.
Nick, do we have a clicker up here? I don't see it. All right, while we're getting the slide advancer, I'd like to thank Nick and the program. I appreciate Nick putting me as the first talk of the morning, of course, while everybody's eating their breakfast and recovering from last night. So thank you again, Nick. My task was to talk about hamstring injuries, proximal and distal. These are my disclosures. And we're just going to kind of get into the mechanism of injury. If we could go ahead and roll that video, guys. So some of you in this room may recognize this person, and thankfully we don't have pictures that are up at the plate anymore. But you know, the injury typically of a proximal hamstring injury is some sort of a trunk flexion and hip extension, hip flexion and knee hyperextension. And we'll see this in just a second. Everybody's thankful we don't see this anymore, correct? That doesn't look good, right? And immediately you can see he grabs right for kind of his left buttock area. And, you know, obviously we're fortunate to have multiple videos. So, you know, proximal hamstrings are certainly increasingly diagnosed in young and middle age. These are certainly not nearly as common as what we see from a muscular standpoint. And if left alone and if missed, these can be debilitating with regard to their outcomes. Distal complete avulsions are uncommon, and certainly may require surgical treatment. So we'll talk a little bit about the anatomy of the proximal hamstring, which is the biceps and semitendinosus attach on more on the medial side, or the medial attachment of the ischial tuberosity, and the semimembranosus is more of a crescenteric attachment on the lateral side of the ischial tuberosity. The anatomy, obviously, in this area is quite wrought with issues, particularly the sciatic nerve, which you can see is listed as number 4 on the screen. So again, the mechanism of injury, an eccentric hamstring contraction with knee in extension and the hip inflection. And the classic mechanism for this is, as you can see, this water skiing injury, where the trunk's getting pulled up, your knee goes into extension, your trunk flexes over with flexion of the hip. This bruising is kind of the typical mainstay of what you see in this treatment, but you can certainly see this with a muscular injury as well. So the examination, ecchymosis, sitting pain, they may have weakness, a palpable defect. You really want to have a good neurovascular exam and have a high clinical suspicion for this type of injury. So the special testing for this is looking at some prone straight leg raising. Again, everybody in this room is very familiar with this. You can look at knee flexion at 90 and 45 and 15 degrees, assessing for the strength, assessing for bilateral planks in different ranges of motion of knee flexion. I find a single leg bridge test to be one of the most accurate tests, or it's one of the most difficult tests. And certainly if you have a proximal hamstring avulsion, this is a very, very difficult test. Standing heel drag, for me, is more of a muscular injury than it is a proximal hamstring avulsion, but certainly can be a way to go about it. Now, imaging for this is very, very pretty much useless, with the exception of if you have a bony avulsion of the ischial tuberosity, as you can see here. For the younger athlete, the physicians and the training and therapy staff, if you have an adolescent, the growth plate still can be open at this point, so it's certainly worth considering. MRI is the mainstay of the imaging. Here you can see a complete proximal avulsion on the right side here, with a complete absence at the ischial tuberosity. Partial tears are also common, and they can also be seen with a proximal hamstring tendinopathy. So this is what you see as kind of a crescent sign, where you have this just a little bit of a fluid underlying the hamstring insertion. It's almost like a partial thickness rotator cuff tear. You get peeling of the tendon attachment onto the ischial tuberosity. Well, when do you treat these surgically? So this has been published, and there's a number of studies out there. But acute 3 tendon tears, particularly in a high-level athlete, you're going to certainly consider surgical treatment. 2 tendon tears with retraction of 2 centimeters or more, and then patients with a 1 tendon tear, or those 2 tendon tears with less than 2 centimeters that haven't responded to non-surgical treatment. How do you fix it? Again, I'm not going to belabor the point, but this has been published before. In the prone position, I use a transverse incision, expose the tendon, which is not such an easy process, but for the sake of time, you isolate the tendon, and then you reattach it by placing anchors into the bone. And that's what the final repair looks like. So rehab-wise, toe touch weight bearing for me the first 2 weeks. Then we progressed to 50% weight bearing, then full weight bearing by 4 weeks, off of crutches by 6 weeks. I utilize a brace between 6 and 8 weeks. Start passive hip range of motion and active hip flexion. Start some isotonics and isokinetics. And then we advanced over time, and typical full sports participation anywhere between 5 and 8 months. And for those of you in the room, and Dave Lintner and the Astro staff, you're welcome. He pitched, I think, 3 games for us, signed by you guys, and then ultimately pitched Game 7. So I don't see part of that ring, but I appreciate you. Any gift would be fine. What are the results? So non-surgical treatment does not do very well in this circumstance. Basically 58% are able to return to sporting type of activities. Surgical results, we published a study in 2012, 52 patients. Average age for this, again, was 48. So I'm not going to overly belabor the point on this, but there's certainly plenty of results out there. These are 39 complete avulsions, 96% satisfaction. Lower extremity functional score was 76 out of 80, Mark's activity score of 10, and 67% were able to perform strenuous activities. So even on these ones that we fix, again, it's not perfect, and all patients estimated their strength to greater than 75%. Well, how about partial tears, and what do we do in this situation of hamstring tendinopathy or acute partial tears, or those chronic partial tears that don't respond to non-operative treatment? This was published in 2013. Again, average age of 43. So this is typically beyond, the majority of what we're going to see on the professional level. We do had 2 college athletes in this study. Again, LAFS scores were pretty good, and all patients were able to return to pre-activity levels. How about a systematic review looking at operative and non-operative treatment? And basically, the patient satisfaction for operative treatment is 90% versus 53% for non-operative treatment, hamstring strength, 85% with a repair, 64% with non-operative treatment. And again, lower extremity functional scores are improved with operative intervention. Again, so the conclusion from that systematic review was operatively treated patients, higher satisfaction, higher return to strength, athletic capacity, overall functional recovery, and acute repair results in higher satisfaction versus the chronic repair. So if you have an athlete that has this problem and you can get to them acutely, much easier to fix than a chronic situation. So chronic repairs, higher rate of sitting pain, neurologic complications. Again, you start to involve the sciatic nerve, which nobody in this room wants to ever see in their lifetime. So if you can avoid having to really expose that and evaluate it, then you're better off. Partial repairs certainly demonstrate better strength and endurance and lower complication rates. Lastly, from a systematic review in 2019, looking at return to sport after surgery, 93% complete tears and 97% of partial tears were able to return to sport again around 6 months. 83% returned to their pre-injury level. And again, earlier surgery returned at a higher rate more quickly, although not significant. Well, how about this? If we can go ahead and play this video. And I apologize. You know, again, we all know in the minor league situation, you don't get the video as good of videos as you do in the big leagues. So we'll follow this guy as he rounds first base and gets the second, trying to leg out a double. And you just kind of notice something right in between first and second. And so it's funny, and for all the surgeons in the audience, you know, things come in waves. You know, whether it's a distal biceps. I think in my practice, I never saw one of these, but I saw 2 distal hamstring semitendinosus tears in a span of 6 weeks and hadn't seen it prior to that. So in this first case, 23-year-old AA outfielder running to first, felt a pop. The second one was exactly the one that we just talked about, was a 19-year-old shortstop, recently drafted, trying to leg out a double, running from first to second, felt a pop in the distal posterior aspect of the thigh. And this is the clinical exam that you can see. You don't see the really well-defined semitendinosus cord-like tendon attachment at the distal aspect in the posterior compartment of the knee. Weakness, deformity, pain. And this is what you can see on an MRI scan. So you follow the distal semitendinosus. And again, this is a distal semi-T injury. So how many in the audience have seen this? I know you're going to see it, but it's not like everybody's seen a proximal hamstring injury, but the distal hamstring injuries are certainly a little less common. Well, what's the treatment? And if you look at some of the literature and you talk to folks, well, what do you do about it? And in this case, in both of these cases, for me, I did an open tendon excision and debridement. And this is essentially what you do. And if you find the tendon, you clip the tendon out, and you can get them back reasonably quickly, so they can be full weight bearing, crutches until they're comfortable, some gentle early range of motion, no resistive hamstring contractions for about 3 to 4 weeks, progressive strengthening, and they can get back as early as 7 to 8 weeks. And there are some reports of even a little bit earlier. So the one case series that's been published was by John Conway and Dan Cooper out of Dallas. You know, ironically, this was mostly found in football players. And so these are 2 busy surgeons out of the Dallas area. They had 25 cases over 14 years among 2 surgeons. So you can, that's not very common. They had 20 professional athletes, 4 college athletes. They followed up on 17 cases, an average of 13 months. They had 12 cases that were treated non-operatively and 7 returned at an average of 10 weeks. However, the big issue is that they had a number of cases that just didn't respond. So with time, they found with acute operative treatment, they did 5 cases within 4 weeks of injury, and they actually got the athletes back in 7 weeks. So they concluded that 42% of the patients failed non-operative treatment, and they recommended that acute surgical resection of the completely ruptured semi-T was a speedy way of recovering. So in summary, and I think hopefully I'm staying on time for Nick, and I know it's going to be in the program chair last year. You know, that's the main goal. So in summary, for treatment, complete acute 3 tendon tears are really in the wheelhouse for surgical treatment. Acute repairs do much better than chronic repairs. So again, we have the ability to see athletes right away. We have the ability to get imaging right away. In the community setting, this can be a little bit of a problem. If you treat these non-operatively, strength deficits can be upwards of the neighborhood of 30 to 40%. So you don't want an athlete to have, 60% of their normal strength and be at a high functional level. Complication rates are generally higher for repairs and complete tears. For partial tears, 1 or 2 tendon tears with retraction should be considered for repair. These chronic tendinopathy, partial tear cases, and we can talk a little bit about, this in the question period. What do you do about this? Do you treat these with PRP? Do you treat them with corticosteroid injections? If you look at an MRI of the pelvis of most of our athletes, a significant number of them are going to have tendinopathy. Now, these patients that have this high hamstring pain and sitting pain, initial tuberosity pain, what do you do about it? There's not much data out there on PRP, although we can intuitively say that a PRP injection is going to probably yield, some improvement and probably not a lot of downside to it. We just don't have a lot of data out there. So if somebody has a number of cases, that would be a great thing to look at and put into the literature. So initial non-operative treatment for this, obviously the rehab is the mainstay, but injections certainly can be an option. This crescent sign on an MRI can respond well to failed surgical treatment. It's like fixing a partial rotator cuff tear. You basically either detach it and reattach it, and after debriding the tendon, or you can basically do an in situ repair, and basically get similar results for return to play for complete tears. These are my 2 guys, and thank you very much for your attention this morning.
If there are any questions, if you can just step to the mics, that would be helpful. I'm curious, we've seen, I think, 2 distal and 3 proximal maybe in the last 5 years. And I know in my first 12 years of taking care of baseball athletes, we saw none. So I'm wondering, is this something that we're seeing more frequently? How many people have seen one in the last 5 years, either a proximal or distal avulsion? And prior to that, in the 10 years before that, how many people were seeing them? So maybe not as frequently. Do you think the incidence is going up, Stephen? What do you think that's due to?
I don't exactly know where the incidence comes from. I think obviously having pitchers not running anymore, being on the bases is certainly helpful for us. I think they're just not ready for the sprinting loads. But again, they do PFPs, and certainly the same thing can happen, in that circumstance. So I don't know where the incidence would be coming from or increasing incidence. I just think it's one of these things that, we catch in waves. I think certain, organizations may see a spread of them. And then, that was the only one in the 18 years that I've been part of Philadelphia. That's the only proximal hamstring rupture that I have seen that's been part of our organization.
Yeah, Chuck and I know have fixed 2. It's interesting. You really think it'd be uncommon for a young, healthy individual to fully avulse their tendon. We see the mid-substance strains or even tears frequently. You wonder if they're just getting faster and bigger, if there could be pharmacologic issues or.
Yeah, I think if you treat proximal hamstring, or if you do these repairs, and this is something you see in your office, this age group is very, very low likelihood. I've treated probably 6 athletes of the hundreds of proximal hamstring repairs that have been at 25 and younger. It is an uncommon thing in the youth.
Chuck Bush Joseph from Chicago. Steve, a great talk as always. And I think Nick and I and James Crook will say, for whatever reason, this virus seemed to hit the White Sox. The only thing I did want to mention, we had one case of a semi-membranosus distal avulsion a couple of years ago that proved problematic, and we wish we were a little bit more aggressive on the management. I think Nick and I said that. And I did want to point out, I actually had one case, a 17-year-old who had a semi-membranosus avulsion that produced a massive hematoma. And for the grace of God, I was going to go take him in and wash him out and do what we do to the semitendinosus. And I didn't. Something went off my head. Actually got a CT arthrogram on him, and he developed a large pseudoaneurysm as the muscle pulled the artery right off of the superficial femoral. If I would have opened him up in a surgery center, he would have bled to death on me. So the semimembranosus is a little bit different, but otherwise a great review. And thanks for the talk.
Yeah, thank you, Chuck.
Thanks, Chuck. Steve, any experience with arthroscopic treatment, particularly in the partial ones? Those can be really tough because you're trying to work under the glute, which is huge in some of these individuals.
Yeah, I've never done the arthroscopic or endoscopic technique for proximal hamstring. It's just not been something that I trained with and was comfortable with. you know, the concept of doing it endoscopically for the partial tear, you know, I guess to some degree makes sense because you're not mobilizing anything. It's kind of like treating it like a rotator cuff. As I mentioned, you can kind of debride it, elevate it off. Honestly, these partial tears or the tendinopathy cases, they're fairly simple. You come straight down to the ischial tuberosity, you elevate the tendon off, you debride the bone, debride the tendon, and you put anchors back on. And, you know, the sciatic nerve really doesn't come into play in that situation because you're staying on the tuberosity. You have no retraction. So I don't find it to be a very, very difficult case from a standpoint of, you know, doing it open. You know, obviously there's the scar and sitting pain, but I think it's fairly minimal.
Yeah, it's interesting. I thought it was a little bit hokey too when I first heard about it, but when you see the skilled hip arthroscopists do it, it's really a pretty elegant surgery. So it's just another option that if you have these players, that an arthroscopic approach for this partial tears can be really helpful. And then lastly, you mentioned this earlier, but you know, the chronic tears are miserable surgically and outcome wise. And so has your kind of approach been, if you're thinking about surgery, to lean towards fixing them early rather than seeing how they do late?
100%.
You get these two tendons, 1.8 centimeters, 2.2 centimeters, you're on the fence.
Yeah, I think I would certainly err towards the side of fixing them earlier. I will tell you, and you may do the same thing or whoever does them in your practice. It's interesting in my practice, our hip surgeons don't come anywhere near this problem, which I find to be incredibly remarkable, but they don't want anything to do with the back of the hip. So they leave that to us. You know, for any of these chronic cases or anything with sciatic nerve symptoms, I will have one of our head surgeons. We'll do it together. We'll do it combined, expose the nerve, decompress the sciatic nerve. I let them, you know, totally handle that. And then I'll fix the tendon and make sure that we're all on the same page. So that's why I do, honestly, anything that's acute is so much easier to fix than the chronic setting.
Yeah, the chronic ones are a pain, much bigger incision, bigger dissection. You have to neuralize the nerve. And in general, I don't think the outcomes are quite as good either. So
They're not.
at this level, I think that if you're thinking about fixing it, it's really the safer play early on where it's a pretty simplistic procedure.
And I think we're really fortunate that we have access early. You know, the issue is that, you know, the community patient who, you know, has a hamstring injury, they go to see, you know, some doctor who says, oh, you strained your hamstring. A month later, they're still having problems. Then they get the MRI scan. Then it takes, you know, 3 or 4 weeks to get the scan. Then they're in the CU 3 or 4 weeks later. And by now they're 10 to 12 weeks out from their injury with a complete proximal tear with retraction.
All right, great. Thanks so much, Steve.
Yeah.
So as the program chair, we're already up 5-0 in the first. We're 6 minutes early. So if I can get Dr. Close and Dr. Bader up, please.
All right, time crunch. All right. I'm Jeremy Close. I work with the Phillies organization. I have the privilege of introducing Dr. Bader. Dr. Bader is a clinical psychologist. She has a PhD. She has areas of focus in sports performance and addiction medicine. She comes with 20 plus years of clinical experience, and she's going to talk to us about THC, CBD in performance and recovery.
What's my go time? 9:15? 15 minutes. We got this. All right, Jill. If I actually stopped and told you that there was a ton of evidence that I get to honor with you today, this would be my only slide. So I could be done by now. So you can start to see the irony of my job, right? You are going to get to have studies. You're going to get to have all kinds of data. I'm going to get to put together different research databases and give it to you. But I just want you to think about how I talk about substance to athletes. I literally talk about a stopwatch. And if you think about it, what I would like you to think about is the last time that you used a mind mood altering substance. I already see some smiles. Lift it up if you have it in your hand. Lift it up if you have it in your hand. Lift it up if that's your third or fourth one, right? That is what we do as human beings. We go up, we go down. We manufacture our mood. And that's what athletes do. The difference is they have to do it precisely. And every now and then, sometimes we overshoot the mark. This is how substances get introduced to us, y'all. We need something. We need relief. We need relaxation. Maybe we needed some socialization last night at the Gaylord. But guess what? When we use a substance, substances work. I don't want to be the first one up here to tell you that drugs don't work. That's why athletes use them. That's why we use them. If I need something, I'm going to get it. And it's a very reliable, dependable mind mood altering substance. I get it. I rebalance my homeostasis. For some of us, we can walk away. For others of us, and I'm a sports psychologist, it gets into our routine. Is that really annoying? It is. It gets into our performance routine. That's what I work with on the daily. This is one of the things I want you to bring your science mind to. I know I don't have to repeat it. When the studies are coming out and everybody's like, oh, cannabis is great, it's doing all of this, I want you to look at a pretty recent study. It says survey. There's nothing scientific, right, about that. That is me asking you if you liked your brew last night. And you'd be like, loved it, fantastic. It was great for me and great for the party. That's perspective. And drugs and alcohol offer us a change in perspective. But if you see that, I want to bring your eyes to the things that we are trying to ask athletes if it's helping. Enjoyment, recovery. I want you to put that in your noodle and talk about it all the way throughout the airport. We talk about recovery differently, right? You talk about it very objectively. And when I get to talk to athletes, sometimes it's very subjectively. How are you doing and what are you doing to get yourself back on the field for mind, mood, physical, and spiritual? So I introduced concepts of this, ergogenic and ergolytic. And I really am the scientist that says, I need something to dependably enhance your capacity and your performance. Ironically, I'm a sports psychologist, but I really don't care about your mood because that's very subjective, right? That's why we have skills to do so. But the things that are ergolytic actually will impair. They will continuously add negatives into our performance. I apologize. I have a sorry, not sorry. If your drug of choice is on here, sorry. The number one ergolytic substance is alcohol. Something to know that alcohol disrupts your digestive tract for 36 to 72 hours. If you knew that, biphasic drug, right? It has a euphoric and then a depressant. Sometimes I'm literally teaching people what their drugs are doing to their bodies. And that's what I get to do on a daily. We're going to talk about THC and CBD, and I'm going to give you as much as I possibly can. Anything else you see, inhaled, smoked, or vaped? I talk to athletes, put this one in your pocket. I said, I don't care if it's not fire. This is called an analog cigarette. I call it traditional, but nobody does analogs anymore. It's really gross and disgusting and smelly. But just because it's not fire doesn't mean it's not heat. And I often tell athletes, this is your most important sport organ, but y'all, this is your moneymaker right here. If you can't breathe by the 8th inning, you don't get as many commas and zeros as I do, right? So we know that. This is the products. Trust me, this part could take 3 hours and I only have 30 seconds. The cannabis of today is drastically different. If you already don't believe me, please start to research. We have potency. Y'all, this is the difference of like, if y'all ripped it up last night with some Scarlet Letter and White Claw, you're not my friend. Like, I don't talk to you. These are the people that wake up and like do shots of Everclear. That's potency for cannabis. When we talk about concentrates, right, we are literally like a single dab, and most of us don't have portion control when we get into it. It's like 7 joints in one hit. I'm going to tell you why that's important to you in just a second. But please know that the THC of today can range anywhere from 0 to 99.9% THC. And we are hitting that, y'all. It's not fringe use. So just know, please, if you don't understand the concept of potency, I'm going to do a pretty quick comparison. Long time ago, in a land far away, Chinese emperor. First time we found it, it's 0.03% THC. That's how high that emperor got. If y'all were living it up in the Woodstock days, you might have gotten a solid 3%. I'm from South Houston. I say we always had better drugs than everyone else. Maybe in the 90s, we could have gotten a hold of a 10% THC, you name it. Right now, literally, I just talked to a female physician that was about to walk into a surgery and continue her surgical day. She was hitting a vape pen that was 91.9% THC. She's up in the mountains. Yep, that's what we do. So we're laughing, but listen, we are high functioning and we're using these drugs, 99.9% THC. I'm going to tell you today what this drug is even doing. We didn't know what this drug was doing in our body until about the 90s. And y'all, I have genes that are older than that. But we were just figuring this out. All the little dots are the CB1 receptors. So the CB1 receptor is what's the lock and the key for the THC. We're going to talk a little about CBD, but let's stick with THC because honestly, that's what's pissing you all off more than CBD. Trust me. And I'll tell you how to piss off an orthopedic surgeon and a trainer in a heartbeat, right? This is what it's doing every single time. These are not negative slides. I always tell people that. I was like, but look at this. If I run hot, y'all, this is no coffee, no nothing. This is how I start my sport day. You don't want more on me. So actually, I might want to slow my brain. This is what athletes tell me a lot. They actually appreciate the reduction in muscle spasticity, right? If I'm looking for a fluid movement and I can take a drug that helps with seizures, right? It helps. I'm like, huh, slows me down, smooths me out. I'll take 6, right? Distorts depth perception. That's really important for y'all's sport. Impairs memory, judgment, and attention every single time. We talked about the clock, and this is what I want to tell you. If we were all stone cold sober right now and we decided to eat it, smoke it, drink it, THC, that we would start the clock for slowed neuronal activity for at least 24 hours. Even if we were stone cold sober, it doesn't matter. Even if you have tolerance, we're slowing the brain down for a full day. And for some of us, right, we might enjoy the distortion of sights, sounds, touch, or time. That's why we could wax poetic about the mountains for 3 hours, pick a song, right? That's why we love this drug. That's why athletes love this drug, especially in baseball. I don't know about y'all, but I would love to distort time perception when it comes to baseball. Thank you for my joke. It impairs memory. We're doing all of this. But look, y'all, these are the skills that we need to be successful. Decreased fine motor coordination, mostly in the hand-eye. And you're like, Bader, but we're not studying athletes. Yo, not yet. These were just regular common people, and we're doing like driving tasks, right? We're doing any kind of cognitive measures. We're throwing cyclists on here. We're throwing rugby players. But I'll tell you, I'd love to have science, and I know it's really inconvenient to get some of your high caliber athletes drunk or high during the season to see how they do that night, right? If I was a research, I'm like, I'd like to know what it looks like in game 3 if we get at least half of the starting roster high. IRB for that one? No one's going to say yes to me, right? So that's why some of these studies are limited. Also, when we go through cannabis cessation, when we go through withdrawal, it's also really important and not a good time to do some research. So this is what the rest of the brain is doing. It's inhibiting sweating, our ability to control our body temperature. And y'all, this happens every single time we use, even if you have tolerance. And I always say this as a sports psychologist. Hey, I get it. But sometimes subtle is really significant. It will decrease nausea. That's why we use it for cancer, why cancer patients use it. But y'all, if you were an athlete and you were a gut athlete and you were going to decide what today was going to feel like, if I was going to decide today if it was going to be a successful performance, when I woke up this morning and said, how am I going to do? If my gut was going to tell me how today was going to be, But if I could decrease that physical experience, I'd probably be a lot more steady. That is why athletes love this drug. If you think about all the things that we do, I will tell you why you hate it though. We are fatigued athletes. We have an increase, and this even happens with chronic users. When we are smoking, we're going to add 20 to 50 beats per minute to our heart rate for 2 to 3 hours. If you want to like hit your smartwatch and see what that's going to be like for the rest of the day, just think about what's happening with athletes. I just bring this in because these are some of the studies that we have, right? It talks about intoxication, but look at the variables that they are measuring. It's not performance, speed, and elbow this. I actually tried to Google elbow surgery and cannabis last night. It seemed like a hot topic, right? Anything. But we talk about confusion and intoxication. But if you see that big spiked line in the beginning, that's how high we get and for how long we get. And this is how impaired we are. That's what I want to teach you about cannabis. This is not a fast-acting drug in and out of our bodies because it's a fat-soluble drug. Nicotine and alcohol are water-soluble. It's literally why if I know your weight and I know how much you drank, I know when we could be done with the drug. But because cannabis is fat-soluble, this is where I'm going to get into your world, it changes us. This is THC in the body, and we know it. Conflicting information. Now we put a lot of smart surgeons, a lot of smart people in the room, a lot of smart physicians. It used to be a vasodilator, and we kind of predicted that and we knew what to do with it. It's now a vasoconstrictor. That is because of potency. Cardiovascularly, we have a tough time taking in oxygen. This is mostly when we smoke. You see the heart again, but you're going to see that chronic bronchitis, the little party person cough, right? When we do that, But most players, and I presented this exact data to players, I get their attention at the bottom of the slide. No joke. And we measured it with cyclists. There's a decrease in early power production. That is literally I saw all like the videos that you need, right? Early power production. I have to go from standing still with a stick, right, to running as fast as my physical possible person could go. And then what I talked about, I've been at your clubhouses, y'all, I don't know, Bosu balls look like Bosu balls, but y'all put water in them. You do everything harder. Everything is about balance. Every minute is about proprioception. This drug significantly disrupts that. We have difficulty maintaining power and work efficacy. But this is the part that's pissing orthopedic surgeons off and trainers. Right now for cannabis, and again, we're having studies. So I'm kind of asking you, maybe your next study is, as you're wondering, why are people having this injury now and not 5 years ago? Why is it taking so long for them to get return to play? My thing lasted 4 weeks, 8 weeks at most. We have an athletic trainer that calls it the weenie butt factor. He's like, I don't know what's going on. This used to work 10 years ago. This used to work 5 years ago. Why is it not working with our athletes now? Please ask them if they are using cannabis. That's my bold Bader question today, because it decreases our bone density. It puts us at risk for fractures. We have better BMIs, right? Like we're slimmer, but no joke. Cannabis is calorie free, right? So we're picking a substance that's helping us change our mind and our mood, and we're not adding one single calorie to our lives. If you think about that, athletes actually have to evaluate their caloric intake for drinking when we do it that way. But I get your, this one, I added it in even last night, so thanks for the slides. The sedation that comes with cannabis and surgery was something that the Mayo Clinic looked at really quickly. Excessive bleeding, difficulties with complications of surgery. Please ask if they are actively using and/or in cessation, if they are withdrawing from cannabis. It changes our perception of pain. We're going to decrease that pain threshold, and that's what we talk about. But when we do that, y'all, that's because we're way more sensitive to our bodies internally. There is an analgesic for some neuropathic pain, but again, a lot of our athletes aren't doing that. I think about that. I always ask if you have soft tissue damage, kind of injury, and please just stay away from alcohol. It messes things up. If you are looking for collagen, ligaments, and bone recovery, I ask you, please stay away from cannabis. Literally. I got my head nod. That's all I need to do. I could drop the mic. This is disrupting our recovery. And not like this one where I feel better the next day, but from the surgical table and the training room back to sport. Please ask. It's going to mess with sleep. This is a part where I'll cut myself off. Please know that this is why I'm in front of you. This disrupted my life as a sports psychologist because it is directly affecting our mental health. It helps with low potency, low doses. I talked about it, you'd have to drink a 10-minute of a 5-hour energy. For real, that's the dose that would help with anxiety when we study it. But look, if my give a damn is turned off, that's what substances do. If my give a damn is turned off, I'm going to tell you I feel better. That's what drugs do. They stop the worry and they stop a lot of our feelings. But when I come back online, y'all, they are intense. Why we have to do it again. It's decreasing our executive functioning. It's worsening our mental health outcomes. But I'm going to put the last one in there for you because this is the one that I talk a lot to teams and coaches. Cannabis in particular is disrupting my ability to attune to 3 feelings: happy, sad, and anger. Literally, I can't attune to it. So it's disrupting my coachability. If you think about that, or potentially my adherence maybe to some of your medical profiles. All right, I will jump the rest. We do have some promising information about CBD, and I think y'all already know that. In the plant, when we broke it apart, the THC was going to be the stuff that got us high, and the CBD was actually going to be the stuff that balanced this drug out. And so if we think about it, that's where we knew the medicine was going to be anyway. It is helping with some anxiolytics, some anti-inflammatory, but y'all, I love you dearly. This is not how your athletes are using. And so y'all can blame it on Bader if you want to. This is not how people are using, right? Because the same thing goes with our lattes, right? When this much caffeine is good for us and we're consuming this much. Same for supplements. And if you have one of these beautiful brains where 1 is good and 2 is better and 3's a party, please talk to your athletes about what they're using and how much they're using. That's what I do on the daily. This is this is like the trendy word for what we're doing. These are traditional methods of recovery. I think they work pretty well. And most of your science that you showed me last night, I had a good time at the science show last night. But look, this is a study. This is a study that says it's for exercise recovery in trained individuals. But when you look at the survey, it says, do you feel like it helps? Do you feel like it helps? So the clickbait, right, is cannabis helps recovery. I think you guys would probably disagree because this person is still in your training room when they need to be out 2 days ago. I'll tell you, there's a lot of symptoms of withdrawal, and that's the last one, so I'll stay on time. Please know what they are. In our DSM now, we have a whole cannabis withdrawal symptoms and a syndrome, and this is what's getting in the way of us. Because if I come in and tell you these symptoms, then you're going to probably think I have a mood issue. The truth is I'm trying to just withdraw from cannabis. And for ladies, twice as hard. Fat-soluble drug, remember that one. This is what it looks like. It peaks at day 4. It lasts for 16. We wish it had this trajectory where it would start to get less bad, but about 16 days, about day 16, it actually has a resurgence, usually right when we're walking out of the training room or right when we're walking out of treatment. And if you don't know the chronic hyperemesis syndrome, right? Look that one up. This is what we can play with. How much you're using, how frequent, and how potent it is. Rates of addiction are going up. Those used to be 10%, 10, 11% the general population for most drugs. We are now at 30%. So that used to be like 1 in 10 has difficulty with substance. Now it's 3 in 10. And y'all, this is the drug that's in our clubhouses. I went to your clubhouses, y'all. 80% of people, just give me hands. How many people, if you know about it, how many people do you think have a cannabis use on your team? Okay, we're going to work a program of honesty later. I just want to ask if anybody has even had a psychotic problem. Has anybody had psychosis? Has anybody had to deal with psychosis on their teams? That's where the sports psychologist comes in. I got 3. That's enough for me. This was my 1-person case study. Again, I can't publish it. I'll let you know I had a professional athlete come in and got clean under my care. And I was just like, hey, you have to do the same workouts that you did. Let's just not use drugs. There's going to be significant increases in all of our lives. So that's one of the interventions I'll tell you. Have some conversations, do some education, ask them at a convenient time, and just be more open with asking the questions. We can have a cool thing. It's called a tea break. If anybody's getting too hard in December, right? Most of the world is a dry January. We have a sober January, and we all hug each other, and we all, bring our juices and our seltzers instead. But taking a tolerance break helps anybody. But please know how difficult withdrawal would be for the athletes if you actually ask them or challenge them to do so. Thank you. Not too bad.
Excellent talk and phenomenal energy, which is the most important part of this. Any questions in the crowd?
That was great information. Thanks for the talk. One question I had is, you always hear people talk about, well, I know what an alcohol hangover feels like, right? Most of us from personal experience, and I don't have that with CBD or THC, I should say. Is there any data on what THC hangover really looks like? Does it have an effect in the same way?
It looks like withdrawal, mildly. So the symptoms that I put up there, whatever they were, mildly. I'll cut it down. It's restless, irritable, and discontent. It would be like you without a morning coffee. Right? How long? Me without a morning coffee, me without 6 morning coffees, right? It's like, but how long can I tolerate that? For some people that use it a lot, is that it'll actually become nauseous. And so it's like the hair of the dog. Think about what we feel like. But if you know what cannabis does, it's euphoric, right? It's intoxicating. It really relaxes us. So withdrawal from anything is almost the opposite of what the drug does. But that's all you have to do is ask the athlete, like, what is it doing for you? And then flip. That's what the morning feels like. They call it it's significant clinical illness when they rate it in the withdrawal symptom. It's not like opiate withdrawal, right? It's not like natural burning of flesh or anything like that. But it's really good. Most of our users don't talk about it like that. That's why they're first thing in the morning. Hard.
For the surgeons in the crew, what about post-op pain relief for people that are getting back onto their THC cannabis product? Are we dangerous about this one?
It's not dangerous. It's mixing drugs. And y'all, and this is, understand medication, and then I understand the word drugs. But for most of the people, when you're doing it, it's really going to decrease our pain threshold. So most of the part is just talk to the patient, like talk to the athlete and really figure out like what they can tolerate and what they can't. We have a lot of athletes that will actually stop using when they get injured because they're like, dude, I can't do that and be high because I can feel everything. And then the next athlete will be like, hit it, right? Because I don't want to feel anything. So it really does change our perception of pain. And for sometimes that's really helpful. That's why like our ultra marathoners love this drug, because if I can't feel my old knees, right, or my wrists, then I actually will exercise more. That's actually the studies that are getting out there, is that if people are using cannabis and exercising more minutes, and we're like, this is amazing. But y'all, I have the OLDs, I've involved knees for my sport. And look, if I didn't feel these, I would run like the gazelle for hours. But the fact is I can feel my knees. So when we talk about that, it's a lot of pain perception.
So I'm just curious if there's any studies that compare smoking THC to like edibles or gummies, particularly with things like wound healing or bone density, where you think maybe smoking might have, more of the negative effect than the actual THC itself?
I do. When we're talking about recovery. So collagen, ligaments, bone, everything, cardiovascular. So that's my thing, and I'll be the soundbite for it, is that if I get to choose and you're smoking and vaping every day, then okay, you can move to an edible. But the rest of it is that neuronal activity. That doesn't stop depending on the route of administration. So for you guys like that, and for you ladies as well, like think about that as that could be one of the things that you might collaborate with for your patient care, is to say like, okay, we're doing it, then can we stop smoking it? Because that would help my cause. And right now there's major leagues right now, some orthopedics that are really pissed off because we're at about a 10 to 11% delay in return to sport based on y'all's protocols. And it's not for lack of adherence. So just start to do the math. And we also have some strange injuries that are coming up too in the leagues that might not have been there before.
Great. Thank you very much.
Okay, it's my pleasure to introduce to you Dr. Roger McCoy. He is a family practice and sports medicine physician at University Sports and Family Medicine, part of Dignity Health Medical Group. Dr. McCoy is board certified in family practice and added qualification in sports medicine. Dr. McCoy's expertise includes sports medicine and the medical care of athletes of all performance levels. He is a team physician for the Arizona Diamondbacks, Rattlers, and head team physician of Arizona State University. He is a member of the American Academy of Family Physicians, American Medical Society for Sports Medicine, American College of Sports Medicine, and the Association of Professional Team Physicians. Today, he is going to be speaking on the management of febrile illness in the locker room, the post-COVID era, a very pertinent and important topic for anyone practicing in the baseball community. Take it away.
Thank you. Nice talk, Dr. Bader. Interesting enough, at about 6, 7 years ago, Drug-Free Sport came out talking about how marijuana can cause problems with an athlete regulating temperatures. And so I took that to heart and was keeping some of my football players at Arizona State out of practice, especially in August and September when the temps are in the hundreds, because they had a certain large amount of marijuana in their systems. And as we talked about being fat soluble, you got a 300-pound lineman. There's a lot of fat there that marijuana does not want to leave the body. So I received a lot of heat from that. But I stuck to my guns and kept these guys out until they were clear. So I only had, and 2 of them did have heat-related illnesses, by the way. Now it's only 2, but more data will come out and we'll look at that in the future. Anyways, thanks again. Talking about febrile illnesses, no disclosures, although I did smoke marijuana in the 70s and I did inhale. We're going to look at illnesses. Normally this would be like a 4:30 talk and everything, but pre-pandemic, but post-pandemic, we need to go back and just remember common things are common. And when Gary asked me to fill in for this talk a few weeks ago, there was a recent case that most of us are aware of that I'll talk about briefly. Again, fever has long time been the clinical indicator of disease in humans and mammals. And the Latin word for fever is febris, and then febrile means related to fever. And it's just a an elevation of a normal set point. And usually the hypothalamus takes care of that. We all know that temperature is diurnal, so we're probably around 98.9 in the morning and 99 or so by 4 p.m. So therefore, the term for fever probably is 100.4, or more people use 101. Again, is fever beneficial or is it dangerous? Obviously, very high temperatures that aren't resolving, it's very dangerous, but it does provide some benefits as far as the phagocytic and bactericidal activity of the neutrophils, cytotoxic effects of lymphocytes, and some of the bacteria just don't like heat, and that's helpful as well. Again, these infections involve body aches, headache, fatigue, cough, chest pain, abdominal cramping, nausea, vomiting, diarrhea. Talking about, we'll go through upper respiratory infections first. The vast majority are all viruses, at least 81% in this one article. And again, the viruses that are being seen the most, obviously, are the RNA viruses, rhinovirus and coronavirus. Coronavirus, obviously with COVID was of concern, but even 2 years before the pandemic, I was looking at one of my ASU football players, simple cold symptoms and everything. And as I'm about to leave the door, he goes, "Oh, by the way, doc, I can't smell or taste right now." And this was 2 years before the pandemic. So we kind of knew a little bit about coronavirus in general until the COVID came out. And the other viruses, the DNA viruses, adenovirus, and of course, Epstein-Barr. Now, the most common bacterial causes in the upper and lower tract are usually like strep pharyngitis and strep pneumonia, Haemophilus, and Moraxella. Moraxella we'll see mostly in kids, so we won't see it too much in adults. Most of these are treated with Augmentin. The azithromycin does not seem to do as well with strep pneumonia, so you might want to consider that when you're prescribing any empiric treatments. So how do we know if it's caused by a bacteria or virus? Obviously, if the symptoms are persisting longer than they should, most of us know most viruses will peak at day 5 and then reduce by day 10. Also, if the fever is higher than what we might suspect, and if the fever starts getting worse a few days into the illness, are all things that might suggest a bacterial cause. The incubation period for a lot of these viruses are listed here, anywhere from 2 to about 4 days on average. Shortest is influenza B, and the longest is the measles. And prevention, we all know these things. We just went through it with COVID. It's the same stuff we were all going through. The other things that we might see are GI issues, and most of those are also viral. Again, nausea, vomiting, diarrhea. Norovirus is the most common. It causes 90% of all epidemic diarrhea in the world and 50% of all cases of gastroenteritis. Again, this was a case I was talking about. Gary had texted me, "Hey, can you give me a call?" He was giving lectures in the Dominican, and we got Dan Halem and John Coyles on the phone and discussed a short outbreak. There were about 30, 40 people on the first day. And then when I checked back, the numbers are starting to climb to close to 100. I never did get final numbers. Gary, you may have some data you can add after the talk, but only luckily a handful really needed extra help. So most of these viruses, or the norovirus, can be treated with over-the-counter meds in time. So luckily, not too bad. They did go, it was simple. This wasn't rocket science. We made them go to Zoom on the 2 days, and they ended up canceling the last day as it was anyways. So norovirus, person to person or contaminated food or water, incubation is just a day barely. And here's the thing that makes it so communicable is you don't need much of the virus particle to get sick. And so that's why it spreads so easily. Again, the CDC estimates 48 million a year, 130,000 hospitalizations, and about 3,000 deaths. Again, knowing to properly take care of food and everything else is the key. And here's showing the top 2 in illnesses and hospitalizations, salmonella and norovirus. Luckily, norovirus isn't involved and isn't the top thing for deaths, but most of us, if you're following TV, know there's been a salmonella outbreak in cantaloupe right now. And so it's out there and it keeps coming around yearly. Again, same thing. We talk to your clubhouse staff and your cooks about all the same proper hand hygiene, washing all of the food, cooking it properly, and not preparing it when you're sick are all key things that we all kind of know about. Good article here, Dr. Conway. took the information from MLB and looking between 2011 and 2016, looking at the communicable illnesses in the clubhouse, and almost 15% of all illnesses resulted in time lost, up to about 4 days or so. So, it's a decent amount when you're looking at a short time period in spring training and through the season. And incidents, 20 out of 100 athletes, high in the minor leagues. Most of it was non-specific, but if you look at gastroenteritis and add the other GI, that's up to about 21%. Influenza is there. And again, a shout out to get everybody vaccinated at one point in time and encourage them to do so. So the respiratory illnesses were most common in spring training, average time of about 7 days. Most of us probably see 3 to 5 days. Peak of the GI illnesses for both majors and minors was the first 2 months of regular season. And again, in our spring training atmospheres, there's a lot of people close together, a lot of numbers. And so that might be one of the cause. And then our athletes that are coming from outside the country, we do have to think about some other things. Busy slide, just talking about all that we talked about, hand washing, health things, nutrition, sleep, and just the basic stuff that we talked about. So the big thing here is, should an athlete compete while they have a febrile illness? But a couple articles that I looked at, they talk about reduced ADH, exercise tolerance is reduced, decreased endurance, muscle strength, increased metabolic demand. So 10% for every 1 degree of Celsius. Increased adrenaline, so you're getting vasoconstriction, and so you can't dissipate your heat. Muscle protein catabolism and an increase in lactic acid up to 17%. And one study showed it can take weeks to months for that to kind of regulate back down to normal. So the question is, do we want to give empiric therapy for febrile illnesses, since most of them are viral? And now we're dealing with athletes. Do we treat them differently than we do with the public? So certain situations might prompt treatment, but these are kind of the things that most of us already know. Temperatures, that are 104, a horrible deep cough and shortness of breath, stiff neck, chest pain, not keeping liquids down, vomiting for more than 2 days, blood in the vomit or in the stool, and then anything that indicates dehydration, we're going to start upping our care. Again, annually, we probably need to just review everything with everybody. Vaccinations are key. CDC showing that people just don't care about COVID, so we're not seeing a lot of people getting the boosters right now. Again, respiratory hand hygiene, food hygiene, and education. Just reminding everybody that spring training and beginning of the year of what we need to do to prevent this. So if you look at, these are just, these aren't real cases, by the way, but we all run into these things when you're traveling. So it's getaway day, and one of the staff or one of the training staff has fever, cough, congestion that started overnight. What do? Well, if this was COVID, we all kind of know what we probably would do, but do you leave? Is the person stable or unstable? Obviously, do you leave them behind and fly commercially? Isolate in the clubhouse or on the plane, depending on the type of plane you're flying. There's not always enough room for that. And plus you're in a tube with circulating air, so I don't know how you isolate. And then do we get tests, treatments, antibiotics? What if the player calls, the training staff and says they have, started the night before, severe nausea, vomiting, diarrhea? Do you call your home docs and get some meds? Use the local team for maybe some IV fluids, labs? Do you isolate? Allow to travel with the team? And then case 3, you have one of your starting pitchers a couple days from the playoffs have URI symptoms, and question is, do you treat them empirically? What if they have a high fever? Obviously, imaging labs probably, hopefully, we get more and more point of care testing. Do you start OTC meds? Do you add an antibiotic? If you're going to add an antibiotic, which one do you take? Upper respiratory, do you augment them? Do you do a Z-Pack? Sorry, azithromycin? And do you isolate in the clubhouse some way or another and mask in the clubhouse? So summary, athletes, obviously, we all know this, shouldn't compete with a high fever, dehydration, or severe symptoms. Again, we're right back to proper hand and respiratory hygiene, isolation, masking, meds. The POC testing, it's easy when it's strep throat. You just put them on penicillin and they're cured. But, we need more of that, and also the COVID testing. And the majority are viral in nature, and so we probably should be treating them as such. Busy slide, just talking about the meds that we use for respiratory infections. Oral corticosteroids are prohibited at the college level and Olympic level, just as a reminder. And thank you.
Excellent talk there. And any questions from the audience? Okay, I'll start with one. Obviously it was a big part of all of our lives, and specifically in baseball during the pandemic. And what did we learn from the pandemic that we can now apply to our strategies for other pathogens and illness?
Interesting enough, when I was looking through the CDC information, there was an article, and I had a slide of it. It was real busy, but it was showing pre-pandemic habits of people at work and post-pandemic. So day 0, 1, 2, and 3, pre-pandemic, most of those people with certain symptoms all went to work. They also looked at whether they were traditional at work the whole time, hybrid, or stay at home. Then you look post-pandemic, and all these people were finally staying home those first 3 days. And so again, I think and we saw what worked with distancing and masking, hand washing. So we kind of proved that all these things work, and so hopefully people will buy into it when our people are sick, and we recommend those types of things.
Go ahead. Thanks again for coming and participating. Do you have any recommendations on what POC testing we should have available in the clubhouse? Is that changing?
Yeah, I mean, we're always looking for something that will give us some information. There's still a lot to be developed. Obviously, it helps to have a rapid COVID test. We're having, a strep test. So again, you can check simple things quickly. For sore throat, use Centaur guidelines if you don't have a quick rapid test. But yeah, it would be nice to have an influenza again, because that's big. At Arizona State, we had a big run of a B actually a year ago. And so knowing that and encourage people to get their, flu shots can really make a difference. A lot more needs to be developed though to make our job easier. So we're still using our clinical skills to make those calls.
And along those lines, is it important to identify which respiratory virus or which pathogen you're dealing with so you understand the spread of it? So obviously we're talking about managing the individual and what's best for them and their return to play. But does it matter which virus we're talking about? And would that imply that more testing to identify that would be important?
Yeah, there is RSV testing, especially for infants and the elderly that it seems to affect. Obviously, there's now an immunization there, so that makes a big difference. But yeah, I think it's tough. I think right now that the common COVID ones are HV and EG5. I don't know, that keeps changing all the time. Very communicable. So if you know they have COVID, you do want to isolate. Luckily, they're not as virulent as the original strains back during the pandemic. But again, a lot of the extra testing, by the time you do some of it, they're already, getting better on most of the cases.
Oh, here.
I want to trump Gary here. Roger, great talk. What are your thoughts on stocking antibiotics in the clubhouse and the early threshold for use? What are your feelings on that?
Yeah, it's, again, I've been around too long. Back in the day, a lot of times, especially at Arizona State, we'd send our, we think, that they're going to get sick, but you're not sure it's early on, but the team's traveling and they're going to be gone for 5 or 6 days. So many times we prescribe like a Z-Pack and have the trainer hang on to it and take it with them. Nowadays, our teams all have the ability to carry meds with them, and then with hopefully the proper use, they can just we can prescribe them while they're on the road. Again, I think most of the research right now is showing better numbers for doctors not using antibiotics as much, because as the numbers show, we're treating viruses. And so, but as I mentioned, there could be times where you're concerned and it's like, okay, do I want my starting pitcher on, game 1 of the World Series out if I could have done something more, maybe to calm things down for him.
One more question.
Yeah, thanks. Thanks, Roger. Excellent talk. And thanks also for stepping up to the plate for the GM meeting and just reassuring everybody. So just wanted to say one thing about someone asked about point of care testing. So the Q test that we've all used for COVID, they're now getting in the approval process for a multiplex device that would have COVID and influenza A and B. So that may add to us as well. And they're in the process of FDA approval. And I think it's really important, now that after COVID, there are other things besides COVID. And people often forget that. I also just wanted to, congratulate you also on, everybody wants a Z-Pak or azithromycin, but it really is not as effective as Augmentin. And, I think it's really important to emphasize that. So thanks, Roger.
No, great points.
Okay, thank you.
Jeff, I saw in the back of the room somewhere is Keith. Here it is.
Good morning, everybody. Mark Scheckendance from the Guardians. I'm going to talk a little bit about ulnar neuritis and VEO this morning, and then we're going to have a UCL study panel. So we all know that medial elbow pain in our throwing athletes is often multifactorial. It can be difficult to determine the nature of the etiology of this pain. And, for us, determining to what degree valgus instability is contributing can be a challenging but very important problem. When you talk about ulnar neuritis, the first thing you need to do is think about upstream problems, thoracic outlet syndrome, those sorts of things. These are things that see us more often than we see them. So if you have an athlete that's dealing with neurologic symptoms in their upper extremity, I think it's always important to at least ask a question about the potential of something upstream. Don't assume always that it's just occurring downstream in the peripheral nerve itself. We're all very familiar with the anatomy of the ulnar nerve. Travels in a very precarious position along the medial side of the arm. Places it can get hung up are at the arcata struthers, in the cubital tunnel where Osborne's fascia is, as well as the flexor carpi ulnaris. These are all common sites of compression and entrapment of the ulnar nerve. Cubital tunnel syndrome can result from compression and retraction of the nerve at those levels that we just talked about. You can see subluxation of the nerve. Ulnar neuritis, we're all very familiar with this, numbness and tingling in the medial elbow, radiating down the ulnar forearm into the ulnar 1.5 digits. You can see a sudden onset with one throw. That can be transient, which is important to remember. Physical findings are really pretty unremarkable, maybe a positive Tinel's of the cubital tunnel and diminished sensation on the ulnar digits of the hand. We need to differentiate neuritis from neuropathy. These are different problems and treated differently. Neuropathy, in addition to the paresthesias, can also manifest as pain in the cubital tunnel, which radiates in the classic distribution. With true neuropathy, you'll also see some weakness in the intrinsics of the hand. Gradual onset is typical, and this hurts during all phases of throwing motion due to both compression and traction. And you really don't want to get to the point where you've got a weakness of the intrinsic. The positive Frohman sign is seen down there at the bottom, the compensatory flexion of the IP joint due to weakness in the thumb adductor. Neuropathy is a different problem than neuritis. Unfortunately, we don't see that a lot in our throwing athletes. Cubital tunnel syndrome, when present, most of us are going to use some sort of an MRI image to look mainly for concomitant pathology. You may want to consider an EMG, especially in the presence of true neuropathy. Initial treatment non-operatively is activity modifications. You might use some sort of a sleeve at night for leaving the elbow in extension, rather than this fancy tape job. Sometimes we just use a hand towel loosely wrapped to help them from sleeping all night with their elbow flexed. You might consider anti-inflammatories. For true neuritis, a medication such as gabapentin, perhaps Lyrica can be used at bedtime. And there's variable success treating non-operative neuritis, with some reports as low as 50% success once it settles in. It's just some quick scenarios that we see in our practices. We generally consider non-surgical treatment for the nerve in the cases of painless subluxation. a transient neuritis at the time of the UCL injury. In other words, the athlete that says, yeah, I got this numbness and tingling, right after I injured my elbow, but that's now gone away. That's different than a persistent neuritis that hangs on. An isolated UCL injury is not an indication in and of itself to transpose the ulnar nerve unless you have significant symptoms. We generally consider surgical treatment for painful subluxation, persistent neuritis, certainly neuropathy. We're going to treat the UCL as indicated. It should be noted that if you get to the neuropathic stage, our outcomes are compromised significantly. You don't want to let things go that far. So our surgical options include an isolated decompression. We usually don't do that on our throwing athletes. It doesn't eliminate the potential for traction as a source of injury and certainly won't eliminate subluxation. So we're left with surgical options such as an anterior transposition, the fat sleeve done with a subcutaneous transfer is a very good way to do it. Subfascial sleeve, which can be a sleeve from the fascia, which you see in the diagram there, or the intermuscular septum. And rarely would you ever consider a submuscular transposition of the nerve. This is what an intermuscular septum sleeve looks like. We're isolating the motor branches there, protecting that. That's the intermuscular septum. We create a sling out of that and make sure that's not too tight, and away they go. So how are we doing with this? Well, not as good as you would think. This is the HITS data that was published about 4 years ago. Only 62% of our players were able to successfully return to sport. You would think that we'd have better success with this operation, but we really didn't in that case. If we look at clinical outcomes after reconstruction, with and without nerve transposition, this is from the Rothman group. Great study. No statistically significant differences in patient-reported outcomes and return to sport between patients undergoing a reconstruction with and without ulnar nerve transposition. Another study, a huge database from Curl and Job, looked at 500 UCL reconstructions in pitchers, 20% with neuritis. And of note, the players who had ulnar neuritis and underwent UCL reconstruction were noted to have significantly lower odds of returning to sport. And also of interest, in ulnar nerve transposition at the time of the reconstruction does not alter the ability to return to sport. So it's a good operation to do if indicated. Let's move on to valgus extension overload. We're very familiar with this. This is that pain back in the posterior medial corner of the elbow that occurs at late extension. That can include both osseous and soft tissue problems, and of interest to this talk, often associated with some insufficiency of the ulnar collateral ligament. This was first postulated by Dave Alchek in a nice cadaveric study they published in 2010. They created UCL insufficient specimens, loaded them, and concluded that valgus laxity throughout the throwing motion may lead to chondromalacia based on the change in the contact pressures and contact area seen in these deficient specimens. Initial treatment of VEO includes a short period of rest and anti-inflammatories. Oftentimes we'll inject these athletes. Arthroscopic debridement off season, careful removal of osteophytes, loose body removal may be needed. A lot of these come back year after year. It's probably due to chronic valgus laxity and or degenerative joint disease of the elbow. We know to be very careful with our resection if we decide to undergo this operation. Caminini did a good study in the lab looking at how much you can take away. Bottom line is try to just take the spur away. Don't get into the native olecranon itself if you're doing this operation. This Dr. Andrews' work from 1995, first study looking at this. Of note, there's a 41% reoperation rate for the athletes that underwent valgus extension overload debridement, indicating that we're probably missing something if we're just doing an isolated VEO resection in these athletes. So how are we doing in the literature? If you look at the results of return to play following UCL reconstruction in players treated with and without VEO, debridement at the time of their reconstruction, there was no difference in return to play, but of interest, the VEO subgroup was less satisfied with their outcome. There was something about their elbows that just didn't feel quite right to them. The conclusion of this group was that perhaps osteophytes may actually represent an adaptive change that stabilizes the elbow during throwing. And if we take those away, we're exposing the ligament to more stress, perhaps leading to more problems down the road. What about just straight outcomes from VEO debridement? Return to play, pretty dismal, 61%. 27% had repeat surgery secondary to stiffness or perhaps heterotopic ossification, and only 77% of players in this group were either satisfied or very satisfied with their outcome. So again, not real strong, good success with this operation. In our adolescents, they do a little bit better, return to play 85%, but of note, in the subgroup with ulnar collateral ligament insufficiency, they had less optimal outcomes as well. And then finally, this is the most recent study published. We talked about this last night a little bit. Great work from Brandon Erickson and the other Rothman group. 36 overhead athletes underwent isolated VEO resection. 18% of the pitchers, 18% of the pitchers required UCL reconstruction at a mean of 13 months following surgery. So I think we've got a lot to learn about the contribution of the ulnar collateral ligament and chronic valgus instability in cases of valgus extension overload and ulnar neuritis. We always need to consider that as a causative factor, and perhaps we can discuss this. We need to be looking a little more closer at that. And with the onset of the fever-view MRIs, which have been useful, and we do quite a bit of dynamic ultrasound to determine whether or not we've got some laxity in that ligament before we undergo any operation. I think that's a valuable tool as well. So thank you very much.
Yes, any questions from the audience specifically to what Mark has discussed thus far? And we are going to have time afterwards. Yeah. Want to keep rolling or yeah. Well, I've got the next talk and we can roll the slides. Oh, here we go. Let's go back. Oops, sorry. Yeah. Well, I want to thank Nick for inviting me up here to give somewhat I don't want to say anecdotal talk, but certainly we're all familiar with the literature. So I'm going to give you my more recent take on my own approach and where I think a lot of this is going, and maybe during the discussion session to talk about a little bit more of the whys and where we are today. But I think the most important thing for me is that one size doesn't fit all anymore. I think we just passed Tommy John's 49th anniversary here, and that single procedure, I think, was what we all did for every patient that walked in our office for the longest time. But I think over the last 10 years, things have evolved very significantly. And we're going to hear from Jeff after myself, Dugas, who's going to discuss the revision side of things. But I think he's had a huge hand in pushing this envelope a little bit. I have nothing to disclose. And we all know about the history of UCL reconstruction. But I think the most interesting thing to me, if you look at some of the original work by Dr. Jobe, we had an 80% success rate. So the numbers are a little bit better today, but not that much different than what he achieved, 30 plus years ago with his original series or original study. And even there was some good work done on primary repairs and was abandoned for whatever the reasons. I think those felt that perhaps the outcomes weren't quite as good. And so, but things have evolved, and there are a lot of different surgical reconstruction techniques that have come up over the years. And obviously, Dr. Jobe's original procedure, Dr. Andrews with his muscle elevating procedure and multiple wraps of the tendon, and Dr. Alchek with his muscle split approach docking procedure, and now more linear constructs that have come in favor and perhaps another step in the right direction. I don't think we know that yet for sure, but on the primary repair side, there were some favorable results very, very early on and just kind of fell by the wayside. And I think until Jeff showed us that we could have some really good success repairing a lot of these tears and reinforcing it with the internal braces. So why do we really need to change anything if we're doing so well? I mean, 85–90% success rates on so much of this stuff now. Well, I think that to some extent, we're all seeing that our failure rates are increasing with the current techniques. I think that we're doing a better job of scrutinizing our own results. There are certain tear patterns that I think that we need to take better note of and maybe address a little bit differently. The first reconstructions are occurring at younger ages. So as a consequence, we're going to be seeing more and more revisions. The game of pitching has evolved tremendously. The increases in fastball velocity alone have caused problems. But I think for me, the much bigger problem here is this entire quest to achieve greater and greater spin and movement on the baseball. And as we like to say, draft by the radar gun, you're going to die by the radar gun. But I think the problem is even deeper than this now. And if you look at the most recent statistics, we see a climb in velocity, and we know that a higher fastball velocity will decrease the average hitter's success against the pitcher. But even more importantly is the non-fastballs that are thrown now and the spin that's being created and the difficulty that it's creating for the pitcher in the batter's box. And as a consequence is creating greater and greater difficulties for us. If you look at the dollars lost, 2016, it was noted $500 million. I think most recently now we're looking at $880 million on the IL DL because of all these injuries that we're seeing occurring. And what I'm going to make one major plea for, and I've talked to a handful of you guys so far, is that we have to have a much better understanding of pitch metrics and how they correlate with health. We need to develop a performance metrics that is married to a health metric. If we don't do this, we're going to see things continually getting worse. The old nomenclature is exactly that. It's old. It's out of date. It doesn't address the problems that we're seeing on the mound. It doesn't characteristically address pitches. One thing I do, and I've really scrutinized over the last year or so, is that every pitcher that comes into my office, I actually photograph their grips and I talk to them about each individual pitch that they're throwing. And you see now, this is just a changeup, for instance, and I can show you multiple different changeup grips and look at the disparity in the spin rate and the velocity in each of these changeups. They're all completely different pitches, and therefore we shouldn't be recognizing them all necessarily as changeups, but characteristically as to what this pitch and this ball is actually doing when it leaves the pitcher's hand. How much movement, how much spin, what's the axis, and so forth and so on. All the things that we're able to measure now that we're much smarter about, which I believe are going to correlate to a very, very high extent with injury rate. So we really need to do a much deeper dive on these individuals. So, but there are other challenges that do remain. Proximal tears probably don't do quite as well. What I like to call the N of 1 phenomenon. We still need to look at each elbow individually and try and design the best program for these individuals. Significant soft tissue loss because of bone. And then the increased incidence of revisions that we're seeing now with generally in the past, at least, poor outcomes. So for me, this is in my bag of tricks, so to speak. The standard UCL reconstruction, or what I refer to as either a dock or a dock loop, which I do not do anymore at all. The primary repair with internal brace, and I have a docking technique that I've been using almost since I started doing these about 9 years ago, that I think does provide maybe a little bit more favorable approach and perhaps a little bit difference in results. What I call an enhanced primary repair, where I put an internal brace in as well as some suture tape augmentation, particularly for proximal tears, and then the hybrid reconstruction, which is the only way I reconstruct the ligament now if I'm going to reconstruct it. And it's not just going to be a repair. These are my current trends. As of November 1st this year, I've got 218 total UCLs, 147 hybrids, 67 internal brace repairs, and 6 isolated repairs. The isolated repairs are actually revision repairs. That's a whole nother level and topic of discussion, which I think requires some thought and focus. But you can see a lot of these are very elite level throwers. So they're testing the procedure itself, and they certainly have done that. Preoperatively, excuse me. Standard x-rays, 3 views, MRI scan. I'm not a fan of contrast MRs. I don't think they're necessary. Obviously, all of us have our own biases. But I think if you sequence them correctly, we can see what we need to see more than well enough. I don't do a lot of stress ultrasound. I mean, certainly kudos to the guys that have an expertise in that. CT scans I don't typically do unless I really feel like I need to map out the bone. This I am a big fan of. Pam Lund is extremely bright MSK radiologist for us out in Arizona. Came up with the fever view, the stress MRI view of the elbow, and it's been extremely helpful to me in terms of altering potentially my approach and which type of procedure I sometimes will indicate for each individual elbow. But I like to take this 5P approach. I say the N of one phenomenon. You have to look at the player. You have to look at their level of play. You have to look at the position that the player is going to be returning to. What is the personality of the tear? Is it a proximal tear? Is it a distal tear? Are there soft tissue or bony challenges there that we have to address? How much time do we have to get this individual back? There are times you may be coming up with a different procedure because this individual is under the gun contractually, free agency wise, and they know that their window is small and therefore we have less time to play with. And then ultimately, what's the potential realistic upside for each individual? So firstly and foremost, to brace or not to brace, always the big question now for all of us when we're dealing with these individuals. The biomechanics that Jeff did early on show that there's no question it's a very stable construct. And then I think additional studies have shown it helps to improve torsional strength as well as again gapping. My docking technique, I started, as I said, about 9 years ago. I think there's some very significant advantages, particularly for those of us that are working in outpatient surgical centers. There's a major cost issue there. It's a single implant and then the internal brace tape. I use generic size drill bits. I have custom drill guides with drill stops that I use, and I just take the standard tap and I cut the handle off and I put it in my drill. And as Dave Lintner says, I do everything with prime numbers. So I actually tap 3 times every time. So, and you can do it quickly with a drill. So this is my docking technique. It's a standard incision, generally about 5 to 6 centimeters. This is a distal tear type that you see there. I put the plastic screw with the internal brace at the apex of the sublime tubercle, add a suture for the distal tear, repair the tear first. Make just a 2.5 millimeter drill hole proximally with 2 diverging tunnels. I move the ulnar nerve back. I do a little bit of a release of the intermuscular septum to help mobilize and decompress the nerve. And then I tie the brace down, Glenn Fleissig, as hard as I can tie it. This is not with an anchor. This is sutures pulled through the medial epicondyle proximally, and I tension it as tightly as I possibly can. And then I sew the native ligament into the brace itself, close up the muscle and so forth. A couple little technical notes. As I said, I do elevate the nerve proximally somewhat to mobilize it. The tunnels, I believe you need to lateralize that proximal tunnel in the medial epicondyle for multiple reasons. I'll touch on that a little bit in a second as well. And then again, I use a knot tire to get in there so I don't have to stick my finger to try and get deep in front of the ulnar nerve there. And I always throw 5 throws, but I tie them at 30 degrees of flexion, full supination. And this is going to force them to get their flexion back a little bit more slowly, but they get it back. We do not generally have motion problems. If it's a proximal tear, I do add this suture tape reinforcement with a baseball type stitch. And I think, as I said, advantages. Oops. Here we go. I think there's a technical ease of tensioning the brace. It does allow for more flexibility on the procedure itself. It allows you to bring some additional tendon in there as well, i.e. the hybrid type approach here. There's less disruption of our proximal UCL footprint. There's a lot of cost savings here to our ASCs. So my indications now, based on my experience, the only absolute contraindication here is if we feel like we need collagen, we need soft tissue. So if we have significant soft tissue loss because you have to remove a lot of bone or the tissue is significantly compromised, then we go ahead and we take a graft. If the if the tissue looks very degenerative, then there are cases I've actually put in a brace and I've had some success doing so. Is the fever view helpful? I think if you have very significant opening of the medial joint space, 3 to 4 millimeters or so, I think for me, it's still evolving. Again, some of these unstable elbows I've put in just a brace and have done well. I'm not sure we've hit a wall yet. I think we're still kind of tapping the ceiling and trying to figure out which individuals are going to do best with this procedure. The proximals do tend to do as well as the distals. This is my own experience. I've got 323 internal braces, 36 pros, 141 college, and so forth. So again, a lot of elite level throwers here. I actually only have 4 known internal brace failures. Now, I have to say, I have not gone back and chased down each one of these individuals, but the individuals that you see from me on the more elite level are people that we follow very closely and we have a good paper trail on. So I can't say this is a complete follow-up, but the bottom line is they're doing extremely well. And I am very, very careful who I put them in versus a reconstruction. I've had 3 patients I've had to go back later on and do all their nerve transpositions on. At 3-4 months, started throwing, began having some symptoms. I haven't had any significant issue with motion loss using this technique, which I think is important as well. So in 18, I started putting these braces in, basically married the 2 procedures, a hybrid plus a tendon graft. And clearly there's some very, very good biomechanical support in the literature. Ken Akazuki and his guys did a really nice study that showed that it decreases joint gapping, that this is a stronger construct when we put a brace in with a graft. And then I took a look at the ligament itself distally and what's happening and what is the ligament doing and what's holding up what. And you find that, again, based on another nice study done by the guys at HSS, that the proximal third of that footprint is the primary resistor to valgus stress. So I said, okay, let me see what I can do with the rest of that sublime tubercle. And there's some fracture studies and so forth. And you can really use the whole length of that tubercle fairly safely. So essentially what I did was just married the 2 procedures. I felt comfortable when I first started doing this that I could put my internal brace in. That spine of the sublime tubercle is very, very strong. And fracturing that would take a tremendous amount of load. I didn't know for sure early on what would happen. And truthfully, I kind of jumped in with all my clothes on. I think that lateralization of your proximal tunnel is very important here, preserving as much of that native footprint as possible. And that's, again, a whole nother level of discussion as to why I believe that's very, very important. But it also, at the end of the day, allows you to preserve your native proximal tissue so you can wrap it around the proximal ligament in your construct. So here are my graft constructs. I use a 2-stranded graft if the proximal tissue is anywhere reasonable. Obviously, if it's a gracilis graft, they tend to be quite thick unless you really pare it down. So you're only going to get a couple bundles in without having to overdrill the medial epicondyle. And then distal tears, I only use 2 strands. If I have a soft tissue deficiency proximally, I do what's called a dock loop. And then I'll end up with either 3 or 4 strands. But more importantly, you add that loop of tissue proximally that allows you to make up for potentially soft tissue loss proximally. And again, this is a bit anecdotal, and I can't prove one way or the other for sure that this helps every one of these particular cases. But as I said, I try and have an individualized approach, a custom approach, depending upon the tear pattern. Theoretical concerns here, biologically, what happens to the graft, the brace itself? I think that we're all seeing that this brace actually heals in very, very aggressively. I don't think that the stress shielding that perhaps we were concerned about early on is a valid concern. Biomechanically, you need to make sure you put your grafts in the right way, or you are going to over tighten the elbow, more on the flexion side than on the extension side. Are we over strengthening our repairs? Are they non-physiologic? I think they are initially, and I think that's a good thing. I do think that's a good thing. Helps that graft to strengthen itself, gives it time. So here's my experience up to November 1st of this year. I've got 289 hybrids, 232 primaries. You can see the overwhelming majorities are pro elbows. So these guys are testing the shit out of what I'm doing here. And so it's giving me more and more confidence that we're on the right track and we're doing the right thing. I've got quite a few revisions now, and Jeff's going to talk about the revisions, but I've got 38 pros that I've done revisions on. And again, albeit I do not have sufficient follow-up on a lot of this, but of the 25 that are more than 18 months out, I have not had any re-tears, which is pretty remarkable. Now, again, time is going to ruin all good results, as Dr. Houston used to say, but they do seem to be trending in a better direction than what we've done before. My complications are the two arthrofibrotics that have required surgery. I know Dr. Paletta had one of them, and I have another one of my own, and both of them in some sense were kind of lost to follow-up. So I think that managing these early, especially if they get a little tight, learning how to manage sometimes their loss of early flexion is critical on the rehab side. And that's where, experienced PTs, therapists, and trainers and so forth, you guys are so critical in these cases. I had one late ulnar nerve transposition I had to do 5-6 weeks post-op. A player came in and said, "Hey, man, my fingers are clawing." So that was a no-brainer. But he's subsequently done well. And then I've had one fracture. I've never had a fracture in 30 years on any UCLs until just recently. And it scared the crap out of me, quite frankly, made me go back and reflect. And I'm going to present the case. This is a major league back-end bullpen guy. Some of you guys have already reviewed his file. He was 16 months post-op. He's a tall, long, wiry guy who was 93, 94 fastball preoperatively, was sitting at 98, 16 months post-op, was a game away from making his next appearance in the big leagues, and pulled off the entire medial column of the distal humerus. The guys that fixed him did just a phenomenal job of piecing this back together. I mean, really near anatomically. He's actually doing extremely well now. His full range of motion back. And there's his most recent fever view of his graft. I mean, he's you can see the continuity of the graft. Nothing happened to the ligament and the construct. So for me, I look at it now maybe a little bit optimistically and say, this was my in vivo study looking at these hybrids and how strong they are. They're a very, very strong construct. And in this case, what failed obviously was the bone rather than the ligament construct itself. I've got 650 elbows that I've tied down proximally with internal braces. I haven't had a single problem with any of those constructs with anybody else. So I think, I'm still optimistic that we're on the right track and we're doing the right thing. The biologics, I think the jury's out. I don't think we have any firm evidence that any of this stuff actually works to enhance or help our reconstructions and repairs. I do it if somebody asks me for it, and that's really my only indication at this point. So in conclusion, look, we've got a rising epidemic here. I think it's a solvable problem if we can help the industry to understand where the problems really lie. Our reconstruction outcomes have been stable, 85, 90+%, but there are individuals that I think that we can improve outcomes on because we recognize risk factors early on. And now can we recover faster? Can we speed these individuals up? Is that a possibility? We're playing with that a little bit. I'm a little bit more cautious, especially with the elite level throwers. I don't think we can afford to have a mistake. And on the revision side, I think we are doing better. And again, Jeff is, I'm sure, going to give us a great talk on that. But I think that we really need to start looking at pitch types differently and come up with a different categorization classification system that marries a health metrics with a performance metrics. And thank you to my staff. What a year. Thank you.
Good morning. Thanks for having me. Quick trip up from Birmingham. There we go. So newest epidemic in what we're doing, revisions, which, as Keith said, I think we all agree we're going to continue to see an expansion of that over time. So a disclosure, I'm a consultant for Arthrex, and I get a royalty on a kit that was designed to support the internal brace technique, and ASMI gets support from a lot of folks, which we appreciate. So the gold standard, and I've said this for 10 years since we started this whole thing with the internal brace. This was never designed. In fact, when I talked to Arthrex about it, they didn't think we could put the tape through the eyelet of the anchor. And I said, sure we can. They said, no, we can't. I said, sure we can. Let's go down to the lab and prove it. So we did it, and I showed them, and then they said, this is going to replace Tommy John surgery. And I said, nope. That's not the point. It's going to serve purpose for some, but not all. And this is still the gold standard. And so revision with reconstruction with autograft has been the thing. And so we can go back a long time. There's data going back 10, 15 years. This was a Journal Hand Surgery article where they said the incidence of primary reconstructions among professional pitchers is increasing, but the rate of primary reconstructions requiring revision was decreasing. And this was published in 2015. Interestingly, their data set stopped in 2013. And in 2014 was the highest number of revisions at the major league level. So I think they came up just shy of collecting the data up to the time before they got it published. And that speaks to the lag in publication. But and this is the group, Josh and Dave and Stan and everybody, Neil, published on 26 MLB pitchers with 2-year follow-up. So a total of 31. They got 26 to get full data sets, and only 42% returned for greater than 10 games at the major league level at an average of 21 months. And this is kind of the numbers that we all talk about. Pretty bad. Career post revision, little over 2 years versus 5 for the normal primaries. So I've said for 10 years, revision UCL surgery is probably one of the worst operations that's still done in the sports world. How many things do we do that have a 50% success rate overall and 60% success rate, and at the highest level, maybe 40% success rate? I can't think of anything else in the armamentarium of what we do every day that is worse than that. In 2019, we had a group that published on, and this was Chris's group, reconstruction, current trends in surgical technique. And the trend at this point was towards increasing number of surgeries over time. And interestingly, they had a bigger group, and it was from 2010 to 2016, average age 26, and about a little over a third were major league. 69 professional pitchers and 77% went back, but only 55 at the same level percent at an average of 18 months. So we shaved 3 months, but our success rate is still in the 50% range at the highest level. And the mean career length went down from the previous group at 2.6 to 1.7. And there was no real difference between major and minor. So again, these are kind of the best data points that we have over the last 10 to 15 years on revision. So if you get the feeling that this is bad, it is bad. There's nothing good about this. So what's the problem? Well, the problem is that no matter which paper you read, the success rate is not very good with revision reconstruction, and we've got to come up with some better thoughts on this. So with revision, post revision careers showing decreased workloads, decreased performance, and a pretty high complication rate, our experience and that I'm talking about today really started since 2017. We did the first repair with the internal brace in August of 13, and I didn't step to the point of considering doing this in a revision setting until 2017. But since then, every single UCL revision I've done with repair with internal brace. And so I chose Division I or above, and I'll get into that in a second, to discuss and look at for publication purposes. But the total number of revision cases done in that time frame from 2017 to last week was 44. So why did I choose Division I and above to report on? Well, because the majority of these people had their primary reconstruction done by people in this room who know what they're doing. And I wasn't going to be dealing with badly placed tunnels, bad grafts, bad rehab, and other confounding variables. If we're going to say something meaningful to the baseball world, I didn't want to base it on a bad starting point. I wanted to base it on the starting point of what we should be seeing, and then back into the other ones if we needed to report on it. I didn't want any outliers in the group. So I chose just the kind of elite level throwers to look at in terms of following that up. So I wanted to take the confounding variables out of it. So this is just a pilot series, one surgeon, minimum 1 year follow-up, average about 3 over this 6-year period. On a method standpoint, I'm using a little larger anchor on the humeral side where 80% of these come from, and in order to get good purchase. And I use a burr, and I think the burr, I put the picture of the burr there because I think this is particularly important. When we're doing these things, we're getting a big mass of tissue, and I've actually started using the burr for primaries. Because I think when you're underneath the flexor pronator mass, we're not necessarily getting a great bleeding surface under there. So I've actually started using this little burr under there when I'm doing primaries. But I think we're getting a much better surface because we're getting this big mass of tissue to heal back down. So in total, look at the total number of surgeries went to the revisions. I took the professional and D1 college guys, and we ended up with 14, and we got a complete data set on 10. So while that's a small number, it's still the highest levels that we were looking at. So average age 25 years, average follow-up about 3 years. Most of them were high grade, partial, like there's a few fibers hanging on, and we could argue whether they were really complete. I think complete's one of those words. It's complete in some parts and not complete in others. So it's probably complete. 8 out of the 10 were proximal, 2 of the 10 were distal. And there was a fair amount of periligamentous calcification, which is probably a post-op phenomenon from drilling into bone. This was a distal tear you can see over here on the right, which there were only 2 of those. And those are a little less common, obviously following reconstruction. So the KJOC scores went from, the standard deviation between them was 12, but the minimum was 61, the max was 99, the mean was 88. So the average KJOC score for a major league pitcher that's healthy is 90. And so these guys got back to a KJOC score of just over 88. That's not bad. When you look at the ASES scores, they're all good. The top line on ASES function is 36. That's the max. So their functional scores are good. Their satisfaction scores are good, low pain. And then the Andrews-Carson score was really good as well. So this is a typical case. This is a 39-year-old. This guy's been pitching for a long time. Through 7 years after his primary in 2011 that was done at our institution. And he had symptoms in 19, unable to complete the season. And I think we can all agree that that's a complete or very, 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 very high grade proximal detachment of his large ligament and flex and a graft mass still attached distally. And so he said, I'm 39. There's no way I got 18 months. I'm not going to do it. Nobody's going to sign me. I got to do this. So this was his case, and getting the nerve out was probably a good 2/3 of the case. And then there was a pretty obvious hole as I split the ligament, but I'll draw your attention to the middle picture and look at how thick that tissue is. And this is kind of what we see when we do these things. They tear right off the bone. It's this big, thick attachment of muscle, of ligament tissue with the native ligament and the graft. And there's no real distinction between those layers at this point. It's a single piece of tissue. And you get a good bleeding surface on the medial epicondyle and you anchor it back up there. You got a great surface for healing, and you can see the internal brace on top of all that. And this is him post-op. So we wanted to get an MRI post-op on him. And this is what it looks like. You can see the 475 screw outlined in the tunnel there. And you can see that that's the same pre-op image I showed on one of the 4 that I showed earlier, but this is clearly healed, good mass of tissue. The ligament tissue looks healthy. And if all of our primaries and revisions look that good, I think we would all agree we'd be happy. And we all know that they don't all look that good. But this is an example, I think, of what good piece of tissue sewn to good bone looks like. So all 10 returned to sport at the same level. 2 have been drafted since post-revision. And the average return to competition time for those 10 was only 9 months. And only one player moved from a starting to relieving role, but the other 9 returned to their same role. So that's important too. So as opposed to what we've seen previously, we're not seeing changes in their performance structure. There were no complications that we knew of. There were some minimal ulnar nerve symptoms in all of them. I think since they all had it, it's tough to call that a complication. They all resolved within a few days to a few weeks. No repeat operations, and there have been no reported failures. As Keith said, I haven't seen these things fail a lot. And so I don't think the failure mode is they re-tear. So the limitations are obvious. There's small numbers and there's selection bias in that. But conclusion is that repair with the collagen-coated tape is likely a more effective treatment than a revision UCL, which we all know to be a bad operation relative to this. So the sort of potential benefits in the short run are, shorter return to play, a lot more reliable return to play, and a lower complication rate. So future directions, less stringent inclusion criteria. Let's get more data. If we have more data for this problem, that's not necessarily a good thing, but we still got to get more data. And those were the co-authors, my fellow George Richard looked all these things up. So here's a little bit of opinion. What can we expect? What can we all expect going forward over the next 10 years? What should we be looking for? Well, I think the internal brace for revisions is here to stay. It's earned its place, and that's not a me thing. That's just, we're comparing it to something so bad that virtually anything was going to be better. So I think for right now, until a better widget comes up, this is here for a bit. I think the hybrid options are going to continue to evolve, as Keith has said, and there are a bunch of different groups of people trying these different types of hybrids with different constructs. And we're going to get to know all those things, and I think they're all valuable. But I think we got to figure out where they fit. Does this particular brand of hybrid fit better for a distal versus a proximal versus a pre-docking or pre-modified Job or pre-allograft or autograft? I think we're going to eventually have that much data on primaries to know the answers to these questions, and they may not all be the same answer. And revision of primary UCL with internal brace to full reconstruction will likely have a better outcome than revision UCL reconstruction to repair following primary reconstruction, with outcomes and statistics similar to primary reconstruction. And that's due to the minimal bone loss we see and the effect from the repair. So I think that we've gone to revising repairs with reconstructions and reconstructions with repairs. And I think we're going to be better off on the whole seeing it that way. And finally, I think primary UCL surgery using a hybrid technique will likely have a mixed benefit in revision settings. I've only encountered this situation once 6 months ago, but I expect that as time goes by, as with everything, we're going to see some failures. Whether the failure is it tears or you see a fracture like what they may not be the same mode of failure that we've seen with previous reconstructions. But I suspect that the rate of that failure is going to be less than what we saw with primary reconstruction with the hybrids. And so I'm excited to see the directions that those are going. Thank you.
Great info, guys. Two quick questions. Number one is, Keith, you already mentioned that when you do a suture tape augmentation, you just pull as hard as you can to tie the tapes. Jeff, there used to be a lot of talk about you got to put a freer underneath and don't overtension. What's your current concept and how you do this? And Mark, maybe you would comment too. I pull as hard as I can. I haven't seen an issue with overtensioning. Do you think that's a real phenomenon if you get it in the anatomic location?
I think that I have not overtensioned it. I don't pull as hard as I can. I still think that I want the tape to be looser than what's under it, not tighter. I haven't done it, so I can't speak to it. I know Keith does that. You do that and the outcomes have been fine. We actually, I think Glenn Fleissig presented a paper, just there he is right there. He can tell you yesterday at the research meeting, and Glenn, you can tell him what you found, but we looked at that in terms of gapping. I just haven't done it. So I do still stick something under there and make sure that it's not tighter than the underlying ligament.
Mark, what do you do?
We pull it tight.
You pull it tight. Yeah. And then one other question, Keith, you mentioned this already, but I've seen recently that we're starting to see early failures where they kind of peel off the epicondyle. It's part of the flexor pronator mass. It's part of the ligament, and they seem to be occurring earlier than the late failures where they just, the ligament degenerates. You talked about repair for those. Have you seen more of those recently? Any thoughts on that, and what's your approach?
Yeah, actually, I've got a classification system now for re-tears, graft tears, and that is in the category of what I call proximal transitional tears. And I think what happens there is you've got, first of all, from the healing side, you've got your tendon and your ligament essentially healing in one layer. It's a scar tissue layer. And I've shown several of you guys the anatomy on the medial side of the elbow. Hiro Sugai, and I implore you guys to pull up his article, Anatomic Dissection of the Elbow. And what you see once you've removed all the muscle is that there are two main septi, which we know well as surgeons, the raphe, between the pronator and the FDS, and then the FDS and the FCU. And the way they come into the medial epicondyle, they sit right on top of the medial epicondyle. And now with all these advanced pitches that we're seeing now, everybody's gripping the heck out of the baseball from this point on. So you've got this massive flexion load or contraction load to the medial elbow flexors, massive flexion, contraction, contraction until you get the ball release. Now you get this ballistic eccentric load on the medial elbow. And if you start to look very critically at your MRI scans, especially the sagittal views, you can see that right where the tears are occurring are right where either one of those two septi are sitting on the medial epicondyle. So these are eccentric load injuries. They're not injuries that occur in layback. And all these patients are complaining of pain, ball release, and follow through. They don't complain of pain in layback. These are very, very different entities. And this is by far the most common injury pattern that we're seeing. And I think most injury tears occur as a consequence. Even the case that Jeff showed there, I think is an eccentric injury. It's not a valgus load injury, but they begin, we get this, we're obsessed with our proximal tunnel and this windshield wipering. And why are they failing proximally? They're not failing at the tunnel. I know Chris Camp and I have had this conversation. They're actually, if they were occurring at the tunnel, you'd see these failures begin occurring from lateral to medial. They're not occurring that way. They all start medially at the apex, right at the corner there, at what I call the magic angle. It's a transitional tear. So again, long answer, but that's why these are occurring. And so these are very repairable, as we're finding out.
Do you think that any of that has to do with the approach, whether it's a split versus a elevation with the RFA? Because you're clearly affecting them differently depending on what approach you use.
No, I don't, because no matter when you go back and you've done enough revisions, you go back and you look at it, there's really no layering of tissue on a revision. It's to discern between tendon and ligament, you've got to artificially create that layer. And so they all heal the same way, I think. Ultimately, I think that's, yeah. I haven't found it. And maybe you have. I can't answer that.
Keith, I want to follow up with Nick's first question about the tightening, because last night we talked about how tight the different methods are on an internal brace, a UCL repair with internal brace. So Jeff and Keith, I want to ask you the question that was asked to me. Do you think the UCL repair with internal brace loosens up after the surgery during the rehab?
Jeff,
I think it depends on how you rehab them, obviously, but I don't know that I have felt that clinically. But I'm not putting them in so tight that I want to see them loosen up either. So I'm hopeful that they're staying the way I put them, because I'm not putting them in so tight that they should loosen.
Yeah, I do think we overconstrain the elbow early on. And I think that's why it takes them a little longer to get their flexion back. And the other thing that I think a lot of you guys see is that they commonly complain of some tightness in their tricep posteriorly. But then the elbow begins to give. And I think in that time frame where you're overconstraining, it's also giving that ligament, that graft, more time to mature. So I think there's a biologic response to that brace as well as a biomechanical. But yes, I do think they're initially overconstrained, but I don't think that's a negative thing.
And it may be good to overconstrain in a hybrid situation. It may not be good to overconstrain in a not hybrid, in just a straight pair. When these are things we don't know, but we'll hopefully find out.
Yeah. Great. Okay, good. Yeah. Thank you, everybody. Thanks, guys.
Nick, you want to move on to the panel? Yes, Chris is here. So. Yeah. What's Chris on? No, you want to stand on that? Okay, sure. We got some case balance. George, we can bring that from wherever. Yeah. We're gonna have George do this. What's up, man? All right, what we're gonna do is we'll present a few cases here. The authors of the case will present their case, and then I'll moderate. We're gonna start with George. I think this is your case. Yeah. Yep, that's Chris. Okay. All right, Dr. Camp's going to present the first case.
All right, so first case here is a 24-year-old right-hand dominant outfielder and second baseman. So this is a non-pitcher. We don't talk about these a lot, but they definitely occur, and I'm seeing them occurring more and more often in position players over pitchers. So that's one of the reasons I wanted to bring this up. Acute increase in medial elbow pain after a long toss session during spring training. I think the timing is important. Admits that he did have some discomfort in the off season. So back in December, felt a little discomfort and a pop in the elbow, but didn't really say anything to anybody. He thought he was going to be okay. As he got to spring training, got to high intent throws, it really came to surface. No pain with batting or lifting, no ulnar nerve symptoms, no prior elbow injuries. On exam, he's got full motion. He's tender over his ligament. He got a positive moving valgus stress test. He's got pain with resisted flexion and pronation. That part's relatively new for him. And his ulnar nerve exam is normal. So we'll send this to the panel here. George, what are your thoughts initially on the MRI read?
Is on. Oh, there it is. He's got clearly a high grade proximal tear. There's some chronic change to the ligament. The proximal half or 2/3 is thickened. There's significant periligamentous edema. I see this slide on the right, your arrow trying to indicate that there's also edema within the flexor pronator, but I think you need the axial or the sagittal cuts to really better assess the flexor pronator. So certainly a high grade tear. Your exam findings suggest there may be a flexor pronator strain in conjunction with it. The rest of the study looks pretty, those two images look pretty good to me.
Yeah, I think that's great too. It was subtle there, but what George was pointing out is that there definitely is fluid in that flexor pronator group. Hard to know if that's a true injury or if that's just inflammation because it's adjacent to the ligament, because you can't get both. So I think diagnosis definitely near complete proximal UCL tear, possible involvement of the flexor pronator. Let's talk about treatment options. Keith, what are your thoughts? How you approach this? Second baseman outfielder, high grade partial proximal tear.
Again, I think you can offer him both, him understanding that this is one of those situations where you really have to know your player, and have an understanding of what his expectations are, from his own body. I think that's really important. Clearly he's failed non-operative management because he had symptoms, as you said, at the end of last year. So
he had them over December in the off season, but didn't disclose it. So nobody was aware.
It's been going on for several months. Anyway,
Correct.
in my bag, this is a ligament that's generally not going to do well. The question is he willing to put up with the symptomatology? So option number one is a short period of shutdown and let him go play and see how he does. Whether or not you put biologics in there, that's, plus minus on your own personal preference. Obviously the other option becomes surgical, and we can discuss, those as well, whether you can get away with just a repair of this. I think maybe so, but I need to see more imaging. I need to see especially the sagittals.
Yeah.
But again, I think this is one of those you have to treat the individual as an individual.
Yeah. And so Mark, briefly, give me your thoughts. This is happening. This is beginning of spring training. So we're sort of in early March, late February, early March with this. How does that timing affect your decision making as to whether or not you try non-operative or you take this player to surgery?
Well, we need to define non-operative treatment as well, and look at the time frame of that. I think to appropriately take a non-operative approach, it's going to take you, a good 8, 10, 12 weeks minimum to do that the right way. If it's March, if it's spring training, all of a sudden he's going to lose probably, close to the first half of the season, be ready maybe after the break. So you got to certainly have that time consideration in there. One of the beauties of the repairs is we can get them going right away, certainly a lot quicker. But I think as Keith pointed out, we need to treat this individually, and with a non-pitcher, you may get away with a non-operative approach here. It's looking at that. It's tempting to just say, that looks like it's kind of come off right there. Let's go ahead and put a brace in this and get this thing repaired.
Yeah, I agree. It's tough. So we had a very lengthy discussion with him, pros and cons of both. I think the surgical management has a higher success rate, but clearly the timing is an issue. But given that it was February, late February, early March, we did say, if you have surgery, essentially the season is done for you. Essentially, your only chance of playing this year is if non-operative treatment is successful. One other thought is that if we do think he's a repair candidate as a position player, his return to sport rate or timing is probably going to be in that 6 to 9 month range. So even if he were to fail non-operative treatment and we ended up doing surgery in June, still he's going to miss this season and still be back next year. So I think this is one where we actually felt like we had a chance to try non-operative treatment. In worst case scenarios, we lose this season, still have him back for next year. So we did try that. Kevin, I'd sort of like to hear your thoughts down there. The rehabbing of the non-operative UCL tear. What are some things that we have to avoid, and what can you do in the early setting? Do we have to shut him down totally, or can we still get him working right away?
Yeah, I guess it depends on how sore he is and how irritable he is, especially with moving valgus tests and so forth. For me, I wouldn't have him throw it at all. I wouldn't have him do any plyos or anything like that. I would work on his shoulder, obviously what everyone would do in this room. The only thing I would add is, I would shockwave him. So I would use piezo wave shockwave to try to get that flexor pronator healing in hopes of stabilizing that UCL. We follow that with laser, and that combination has been extremely beneficial for tendon types of problems. And I think that's a powerful adjunct. And then gradually get him into a plyometric program, gradually into a sock throwing program, and then throwing.
Great. Well, and one of the things I think is also helpful too is we sort of have a sort of a drop dead date on these. Oftentimes we'll say, we're going to try non-operative treatment, but if you're not back by July 1st, we're going to pull the plug, move to surgery, try to have you ready for next. Sometimes that can be helpful and appropriately motivating to kind of, so that way you're not just sort of dragging this thing out. Because what we don't want to do is have him fail in September or October, and then he misses the following season as well.
Yeah, I would tell you, maybe you've had a great outcome, obviously, with this guy, but I think you can have almost a similar outcome if you had operated on this and put a brace in it. I don't think I would automatically say that this guy's done for the year, and I certainly like to hear George and Jeff's comments, but you fix him at the end of February, early March, April, May, he's back DHing, and then, he may be back second half of the season easily from his position in the field. I think that surgery doesn't necessarily mean a death knell for the season on this particular player. So
yeah, and I told him too, if we did surgery in early March, six-month return, we're probably looking at August, September in the minor leagues. Not a whole lot of baseball going back, going on at that time, but we could potentially have him in, fall instructs and certainly line something up. Yep, Dr. Andrews.
There's only one thing that I would add to the conservative treatment, and we don't think about it in the baseball throwing elbow, and that's a dynamic brace. I tried for years to try to figure out what kind of brace could I put on a thrower's elbow that they would tolerate. And I finally came up with one, I don't know, some years ago. I'm not here to advertise it. I don't make any money off of it, but it's been extremely important in non-operative treatment using that dynamic brace. And within a couple of weeks, a lot of them are back throwing. I've had major league pitchers use that brace in competition. So if you're going to go non-operative with this, I would certainly think about that dynamic brace. And if you're interested, I'll tell you who makes it in the hall or something. But that's one thing you can add that it's been unbelievable as far as the use that I've had of it.
Jimmy, I think I speak for everybody. We are interested. So yeah, so you can tell us and I agree with you. So we actually did use, there's an elbow sleeve. It may be a different one than what you're describing. So it's an elbow sleeve that has the ability to put little hinges on the inside and the outside of some straps to control stability.
Much better than that.
And well, good. Well, I think it's helpful. I do think braces have a difficult time really controlling varus and valgus, but I do think that it's a signal to the player, to protect it and take care of it. So I agree wholeheartedly. I think it can be really helpful, especially when you've got a lot on the line in these cases.
With the brace, do you allow full motion, or do we protect motion in these situations?
Yeah, great question. I generally let progress motion is tolerated, just to avoid valgus stress. Anybody different? Yeah, motion I'm okay with. So fortunately, he got back in games as a second baseman at 3 months post-operative. We did wait until the 4-month mark to get him out into the outfield and progressed quite well. So he's 2 years out now and is still doing well. It's progressed nicely. So in this case, it worked, but this is one where I think you want to be careful. You got a time window, but it's a relatively short one. Don't let it linger on. There we go. Move on to another case here. So 22-year-old right-hand pitchers at the high A level, young pitcher, high level prospect, had an acute pop on one throw, unable to continue. Generally, his elbow's been pretty healthy, so this was sort of a new problem for him. Did have some temporary numbness in the ulnar digits that resolved within a few minutes. That had never been an issue for him before. Has clear medial elbow pain. On exam, 5 to 135, which is a little tighter than normal for him, but not dramatically so. He's tender over the ligament, positive moving valgus stress test, no pain with flexor pronator testing, and the ulnar nerve exam is normal. Maybe we'll start down at the other end and come this way. Jimmy, what are your thoughts here on this case? You see his MRI there. It shows essentially high grade complete proximal tear.
This is a 22-year-old at the high A level. I don't know how long he's been there, but that looks like a pretty significant tear. And I would think that he's had trouble before. And I bet you if you question him and go back in his little league history or youth league history, you'll find out he probably may have forgotten about it, but he probably missed 2 or 3 weeks at some point with medial elbow pain when he was a kid. I don't believe this is the first time this ligament has been injured. But in this case, he's probably headed for a surgical procedure. By the way, for me, that's periligamentous edema that you see there. There's nothing wrong with his flexor, at least the best I can tell looking at this. But, you know, in these cases, a lot of times, and Jeff can verify this, you're trying to decide, are you going to do a reconstruction? Are you going to do a reconstruction hybrid? Are you going to do a repair with an internal brace? And a lot of times you don't make that decision until you open it up and you look at it and you really get all the cards on the table. And then you move forward with what is the best procedure. But for me, this looks like probably going to wind up with a reconstruction of some sort.
Yeah, Jeff, what do you, I'd love to get your thoughts on this too. Cause to me, the ligament itself looks like it's reasonable quality, but short. And so this is one I would have concerns with, but maybe repairable. What are your thoughts?
So I think this is the guy that makes his living doing this. And so I always say, if there's not a time benefit to the person, reconstruction is still the gold standard. So if this guy said, if this happened in June and he's got a pitch in February or he's done playing, you really only have one option. But he's 22 in high A, so that's probably not the case. So you would imagine that with this condition, this guy, this is not the last opportunity he's going to have. And unless he is really under the time gun, I think you go into it if he's amenable to, if the tissue is amenable to it and it's great for repair, fine. But if there's no time benefit to him of having a shorter recovery other than the fact that it's shorter, I don't think we ought to be doing repairs in those situations at this level, at the pro level. So I think when there's a time benefit or a really good reason, or an infielder, outfielder where you really don't, you know, like the previous one, I don't know that I wouldn't push a repair on this guy.
Yeah.
And I would make it a game time decision. But again, I think the time element of it is important.
And I think that's a great point. I think this audience knows that well, but I think it does depend, and it needs to be pitcher dependent. Obviously, this is a guy, this is, you know, he was just drafted last year and is already high A level this year. He's got a very high ceiling. So I do think it's important to know how the player feels about their future, how the organization feels about their future, how the agent feels about their future. I think all of those things are important. It was pretty clear all those groups prioritize the long term over the short term in this particular case. So there's the diagnosis. And also, I think we all would agree, maybe no, I mean, this is a one-time acute pop, but any role for non-operative treatment here in a pitcher? Mark?
I don't think so.
Yeah. Okay. All right. So we could talk briefly graft preference for everybody. If he does have a palmaris, is that still the go-to autograft option for reconstruction for everybody? Any different? Okay.
Yes.
He did not have a palmaris. So I went with hamstring, contralateral side. So, and this was a hybrid. This was this was pre-COVID. So 4 years ago. So a little bit early in the hybrid experience, but here it is. You see, so his ligament elevated off, repaired back down, graft with a suture tape internal brace augmentation over the top. And here's the final construct, afterwards. Ulnar nerve, we did not address his ulnar nerve done through a flexor pronator split. And fortunately was able to get back. We did put him on a expedited rehab and recovery based on how he was doing. He progressed quite well, was back at the high level again at 10 months and has since done well, continued to progress in the organization. So I'm gonna go to the third case here, which I think has got a few different elements and level. Hopefully, I think will generate quite a bit of discussion. So 30-year-old, so older pitcher, MLB levels, had several years of service time, so he's been there for a while. Had a previous reconstruction with nerve transposition in 2018 and recovered well from that and has generally done pretty well, not had a lot of elbow issues. He felt a crack in the posterior elbow on one pitch during a game. Didn't say anything, he grimaced a little bit, but nothing substantial. He ended up staying in the game. 2 pitches later, then he felt a pop in his medial elbow and then unable to stay in the game. Had numbness in the ulnar nerve distribution that persisted for several days. On exam, he's got full motion 0 to 145. He's got posterior pain with forced hyperextension and impingement. He's tender over his ligament, positive move value stress test. He does have flexor pronator weakness, and he has a transposed ulnar nerve, but he does have tenderness when you do a Tenel over the nerve in that transposed position. So he's got a lot going on. This is sort of a hot elbow. Here are his X-rays from it following. He had previous reconstruction, so you can see that, and then his MRI and then a CT scan. So. Mark, what are your thoughts here initially on these imaging?
Well, I'm glad he showed up in your office and not mine. He has, from what you've said, he has everything wrong with his elbow, right? I mean, he's got a ligament problem, he's got a bony problem, and he's got a nerve problem on top of that. So clearly a complicated case. I'm looking at that humeral tunnel on that AP view on the left. It looks like it's a little medial to me. I don't know if that'll play into your plans for potential revision, but that's something to consider and look at. He's got a little ossicle there down by the sublime tubercle, probably sitting in his graft, and he's got a little fractured osteophyte there in the back. So you certainly have your hands full here. Most likely looking at a surgical procedure.
And Keith, you talked a little bit about those transitional tears with the flexor pronator, the ligament. Tell me what, and I didn't give you the stir image here, so I apologize for that. But what are your thoughts here on how that looks, and how would you address the ligament itself?
Yeah, this is exactly what I was talking about, actually. This is one of those proximal transitional tears. It's more advanced. They start small and they get bigger. There may be a small tear there initially, and then it just propagated. But I would scope them, clean them out. That may be a symptomatic osteophyte in the back. I mean, obviously, I'd look and see what his sagittal images look like. But this is one that I would tell you that you can do a primary repair of that ligament and some suture anchors for that flexor tendon as well. So, and I think he'd do very well.
Okay, so you would probably repair the ligament with internal brace.
Yeah, obviously, game time decisions, Dr. Andrews said always, but my intention would be based on that scan to do a primary repair.
George, what are your thoughts on that that fractured or broken piece in the back of the elbow? What do you do about that? Can you leave it alone? Do you need to take it? If so, does that affect what you do with the ligament?
Question I have for you is, do you think that was part of his symptom complex, or is that an incidental radiographic finding? Does he have physical exam findings, tenderness in the back? Does he have pain on so-called bounce test or hyperextension of the elbow? I don't think every one of those needs to be addressed if you think it's an incidental finding and asymptomatic. So I guess it would depend in this case on his clinical history and exam findings.
Yeah, I agree. And I don't think there are many 30-year-olds at the MLB level that don't have some level of arthritic change in their elbow. So it's rare that you get a normal CT scan. And the reason I got the CT scan on him was because he was symptomatic. So he was having pain with posterior impingement, and he very clearly localized that to the posterior elbow, which was separate from his medial base pain as well. So it did seem to be symptomatic.
So in that case, you need to scope him and do a excision or debridement. I think I would obviously scope him first. I think you need to be efficient and timely with your scope and minimize any elbow distension, because that could affect the ease of your exposure immediately and affect your tissue plane. So if you're going to scope him, be efficient, be effective, and get to the point.
Yeah. All great thoughts. Well, I'll show you what we ended up doing. So the plan was revision, ulnar nerve nolysis, which is Jeff mentioned, or sometimes that's half the case. And then revise the subcutaneous transposition, UCL graft repair and revision, recon with internal brace, and I'll show that in a little bit, and then excision of that osteophyte. So here's his ulnar nerve, which took us a little bit. Interestingly, he has a massive medial antebrachiocutaneous nerve as well that was also isolated and dissected out. That is an anatomic variant that you can see. The MABCN sometimes is big enough it looks like an ulnar nerve. And actually, because his nerve was transposed, we had pretty easy access to the back of the elbow. So actually just made a small little capsulotomy to get that fracture olecranon osteophyte. And there it is. I did not use any tools to take that out. That's just a little forceps and pickup, just grabbed it and pulled it out. And to be honest with you, it was a little bigger than I expected it to be, pretty sizable. So Keith, if you see that, if you know that you've got that and you're taking it out, does that affect your decision? Because we talked yesterday at the research symposium about how having that bony congruity probably contributes somewhat to stability. If you take that out, does that make you more weary of doing a repair? Are you more likely to go to reconstruction, or is that totally separate from your decision on the UCL?
In this case, it's separate. When that piece is that unstable, there's no way that it's providing any inherent stability to the elbow. So it's like a loose tooth. That's all. You take it out, and whether you do it through a capsulotomy or through the scope, obviously that's dealer's choice. But that's why you need to see the other imaging. You need to see the sagittals and so forth to help plan your procedure. But yeah, no, I don't think that's affording you any stability. So that wouldn't change me.
Okay, good to know. Good to know. So took the
Let me
piece
say
out.
one thing about
Yes, sir.
the posterior medial arthrotomy that you make there, take that out. We've forgotten about really some of the function of the posterior band of the ulnar collateral ligament, and it stabilizes the olecranon tip against valgus stress. So when you make this incision, you make it vertically back there and right at the back of the posterior band. And when you take that out, you really do two things. You look right at it and you pluck it out, but then you put mattress sutures in and you tighten up that posterior band to the posterior medial capsule to stabilize that part of the bony anatomy. And we forget about how important that was. That was publicized and made important by what's his name from Mayo Clinic.
O'Driscoll.
Oh,
John O'Driscoll.
No, Bernie Morey is one that popularized that. And he wrote an article about it. If you hadn't looked at it, you ought to get it and read it. Bernie Morey is the one that did it.
Yeah, that's a great point. So and I think it also helps to make that as proximal as possible to get away from the ligament complex too, and then close it tightly. So there was his elevated ligament, which we then repaired down. And actually, I did add a graft to this one. So formally repaired it with an internal brace and added a graft as well. In this case, so that's the final UCL reconstruction. And you can see his medial epicondyle is relatively bare there. So after that, put suture anchors into the medial epicondyle and sutured the flexor pronator mass back down, and then did a revision transposition here for the nerve.
One quick technical note I will tell you on that. I would say, obviously, you did a beautiful job and he's done real well. But when you've got a combined flexor tendon tear, I would highly recommend putting your anchors in before you pass your graft, just in case you end up encroaching on your tunnel or whatnot, and you end up messing up your graft.
Yeah, great thoughts. Yeah, I do think you got to be careful there not to have tunnel anchored convergence. And then real quick, we've got to wrap it up. Thoughts on what you would tell this player for his chances of getting back to play and timing? Maybe let's run down the panel. What are his odds of getting back to pitching at the major league level, and how long is it going to take him, George?
2/3 chance, so 65%. It's going to take him every bit of 14 to 18 months.
Yeah, again, I would have repaired it, and I would have given him a 12-month timeline actually to repair, but with the repair, not new graft tissue. Yeah, I agree with George on this timeline.
Yep.
Yeah.
I'd say 60-40, 16 to 18 months.
I would bet it's in the 70% or 65, 70%. I agree with both of them. I tell them with the recon, it's 14, 15 months, maybe more. With the repair, I'd say 10 to 12.
Yeah, I wouldn't rush him. So you'd have to see how he did. I wouldn't let him start any throwing until around 6 months.
Great. Well, thank you, panel. There, we wanted to end on that one. I know it's not super optimistic numbers, but that's what we're dealing with. We're going to see more and more of these. So I think we'll cut it there. Thank you all to our esteemed panel for all of your great insights.
Good morning. It's with a great deal of pleasure for me to introduce a good friend and an associate of mine, and that's Dr. Kevin Wilk. And he's been given the Frank W. Jobe MD lectureship this morning. So let me just tell you quickly about him. He's been a physical therapist now for 40 years and he's a graduate of Northwestern University Medical School program in physical therapy. He is the Associate Clinical Director and co-founder of Champion Sports Medicine with us in Birmingham, Alabama. Kevin is also the Vice President, National Director of Clinical Research for Select PT Medical, and he's also the Director of Rehab Research at our Andrews Sports Medicine Institute in Birmingham. Kevin has published over 167 peer-reviewed journal articles and has published 27 articles in the last 3 years. He has edited 11 textbooks. Kevin has been selected to the Sports Physical Therapy Hall of Fame. He has received the James Andrews Excellence in Baseball Award, the Peyton Award, and the Education Award from the sports section of the American Physical Therapy. Dr. Wilk has lectured internationally and nationally at over 1,500 medical conferences. Most importantly, Kevin is an active, very active clinician, researcher, and educator. Kevin, come up and I'll present you.
Thank you very much. It's certainly a privilege and an honor to be here. And certainly humbled to give this presentation, to say the least.
Oh, let's give that a try. As I mentioned, I'm humbled to give this presentation. If I could have my talk up, that'd be great. And I want to thank Dr. Verma for the invite. Very appreciative as well. You can go back one. There we go. And I'm just going to basically talk about UCL rehab a little bit and how we've thought about it through the years, as Dr. Andrews mentioned. These are my faculty disclosures, none of which will come into play. I'm honored to give this talk in the namesake of Dr. Job, to say the least. And I'll try to talk to you about what we've changed over the last 40 years and my 35 years in Birmingham with Dr. Andrews. So what I've learned is basically what I've learned from Dr. Andrews and our wonderful team in Birmingham, Dr. Dugas, who you already heard, Dr. Kane and Dr. Fleisig. And it's really been something to work with them for the last 35 years. And my knowledge has grown because of them, but also because of all these people that are in this room as well. So you've all taught me a great deal. So in '89 is when I moved to Birmingham, and at the time we were pretty much following the Dr. Job approach to UCL reconstructions. 5 degrees of extension per week and 10 degrees of flexion. And about 5 years into that, Dr. Andrews said, just get them moving faster. And it made me very paranoid. Up to that point, we were 8 to 10 weeks to get full range of motion. And now he said, just go as fast as you basically can after a reconstruction. The other differences was when we started our interval throwing programs. We routinely, as Dr. Kane's Dr. Kane's publication, American Journal of Sports Medicine, we routinely started people at 4 months. And return to play was really a 9-month goal, to say the least. And now asking Dr. Andrews, well, we'll start people throwing maybe at 5 to 6 months. Return to sports 12 to 18 months. So everything's been pushed back a bit. We used to use a posterior splint on everyone, and now we just use a range of motion brace. That first week, we don't move people. We've had people like, some of you might recognize that gentleman in the middle, Jose Rijo. He had 3 UCL reconstructions. You tend to run out of grafts after 2. We also dealt with some stiff elbows, and occasionally we still see that sometimes in extension, but really more the traumatic injuries and not the pitchers per se. And in this picture, what we've learned is to do low load, long duration stretching. Some joint mows, but just like an ACL patient who has a flexion contracture, we use low load, long duration and not get super aggressive with manual techniques. It's a team approach, obviously, as everyone in this room knows. You guys know the team approach the best. Physician, PT, ATC, strength and conditioning coaches, the player, all on the same page. And when you think you know it all, obviously you get humbled really fast with a player or a complication, to say the least. But we need everybody to be on the same page, to say the least. Don't rush the process. I asked several of you preparing for this talk, hey, what's changed in your rehab? Some of the really experienced ATCs and MDs through the years. And it's just take your time. You got tons of time. For me, what stresses the graph most commonly is obviously excessive flexion, the external rotation that you see with throwing motions like plyos, weighted balls, types of things, and certain intervals in the rehab, which we'll talk about. And obviously with revisions, we go much slower. Dr. Fleisig has shown us that when we start our long distance throwing program, when a person, whatever that means to them, their max distance, the forces on the medial elbow go dramatically up. So we're pretty slow. And in Birmingham, we've always been a 120, 150 duration long toss person or advocate that. Now we have individuals that love to throw 250, 300. We try to discourage that, but if it's organizational philosophy or if it's an individual's goal and they do well and the mechanics don't change, well, maybe it's okay. I'm not sure. This is from my friend Ron Porterfield, showed me a couple videos, you know, where nowadays things have changed dramatically. Every throw is videoed. Every throw, there's a radar gun. I remember the days where we thought that radar guns were bad, right? For those who've been around a long time. Now, it's so valuable to use a radar gun to record, adjust, and modify. There's so much technology available, spin rates, arm position, markerless motion analysis. None of that was available in the beginning. So nowadays, it's fantastic. You get so much data. And what Dr. Meister was saying as far as velocity versus spin rate, couldn't agree with more. Couldn't agree with more. It's velocity and spin rate for sure. Adjusted interval throwing program. Jamie Reed and Ron Porterfield, Ken Crenshaw always used to tell me with some of their individuals, just write it in pencil. Ron's going to laugh. Just write the interval throwing program in pencil because we're going to adjust it so many times. And I said, absolutely. And I couldn't agree with more. Again, we're worried about the throwing hard and our rehab process. And we tell our rehab people all the time, there's certain points in the range of motion in that layback where stress is going to be increased on that reconstruction or the internal brace or hybrid. Dr. Fleisig has taught us when that late cocking phase, it's around 64 Newton meters of force. Theoretically, every time a person throws maximally, they should tear their UCL. That was a study by Chuck Dillman years ago looking at cadaver strength, but they don't because of flexor pronator muscle mass, because of bone absorbing. This is an interesting study by Dr. Chalmers who taught us that when in season looking at ultrasounds, with throwing, the UCL increases in thickness. So we know that some stress on the tissue is good, but what's the implications as far as laxity and also rest and so forth? As you all know, you're probably psychologists, you don't know it yet, or you've realized it already, the psychology of rehab. And when you master that, I think you master the game of rehab, staying positive, being a cheerleader and all that. Also, athletes, you know, are all different, as you all well know, especially the people in this particular room. When we tell a young person, because I deal a lot with high school kids with this problem, and I say, you're not going to throw for a while, they look at me like I'm crazy. I don't know what I'm doing, but I have to delay that with purpose. I have to delay that with reasons for not throwing. Let's work on your core, your hip, the biomechanical factors, and I explain all that, the importance of hip strength, as you all know. Is tighter better? I was intrigued by the panel and the presentation and so forth in the panel and the discussions prior. I don't think tighter is better. I think a little tighter is better. But I know that looser in the beginning is bad. And so if you have someone that's loose in the beginning, good luck. That's going to be a significant challenge, to say the least. And Dr. Dugas has done some great work looking at the biomechanics of this, the internal brace versus the reconstruction. Weighted balls. Weighted balls are great, and they've been around forever. Weighted balls started in 1980s by a guy named Coop Duran. Coop was at the University of Hawaii, strength and conditioning. Used to talk at our baseball course every year. Underweight, overweight definitely increases velocity. But you're in a unique situation being with a team where you have eyes on. It's the high school kids, obviously, the young people that think more is better, and they go heavy with balls and so forth, and they do it all the time. Mike Reinhold has taught us that that weighted throwing program does one thing in particular. It increases the layback, and that layback seems to be a problem with the UCL. at least one mechanism. So Mike did a study on that in the Journal of Sports Health, and I'll illustrate that in a second. And then we did a study, an 8-year study with the Rays, looking at risk factors with range of motion with elbow injuries, and the increase in ER correlated the highest for elbow injuries, in particular UCL. So this is a paper by Mike. His study was with 15-year-old individuals, and 25% of the individuals doing the weighted throwing program got injured during the actual program. That's scary. 3 UCLs and 1 olecranon fracture. The second study he looked at with the same data points was what were the reasons, and what significantly changed other than velocity going up about 4 miles per hour, or excuse me, 4%, was that the layback significantly increased by 5 degrees. Restoring extension early, I don't really think is a problem, but one thing I've learned, and Dr. Paulette and I talk about this all the time, he's taught me a great deal, is I don't really push the flexion anymore. And with the internal brace, I have seen a little tighter into flexion. I'm sure there's nuances that the physicians can address. I also delay throwing with purpose, as I mentioned before, and a big statement which Dr. Andrews has taught me to never say always or never. I always do plyo. Sorry, Dr. Andrews. And I think he agrees with that. We always do plyos first, and they do plyos for a period of time with 2-hand drills, progressing to 1-hand drills. And we monitor them significantly as far as load. And we're going to have a presentation on that. This is some other work that we've done for years. We've done a very progressive program as far as our interval throwing, and I think it's worked. But you all know in this room, you're the experts, to say the least. We need deloads. We need phases where we decrease the volume and the intensity. And we've learned that maybe the hard way. But I think a lot of us were doing that anecdotally already. But now we need structured programs to actually show that this is the way, and how long of a deload is imperative. Again, as I mentioned, Jamie Reed, Ron Porterfield, Ken Crenshaw, the whole list of you have taught me that through the years. And this is some videos that Ron was nice enough to give. Plyometrics. I'm a big plyometric fan. So Vern Gambetta, some of you might remember a guy named Vern Gambetta. Vern and I wrote the first paper in '93 on plyometrics for baseball players. And Vern was instrumental in teaching me about plyometrics. And so you all know plyos, but this is one of the ones we use a lot. And obviously this was during COVID. This is a big league baseball pitcher. And I always tell my young individuals, meaning high school and college, if you look at that guy doing it, he is locked in. And what I mean by locked in is arm is at 90, his elbow is at 90, and he's not fluctuating in different planes. He is locked in with shoulder stabilization. And I know we were going to talk about a criteria to return to throw, but when you can do that with a 2-pound ball, fast and hard, and you can come back in a good layback position, and you don't move with my rhythmic staves, I feel really, really, really good. And that was 3 reallys. 3 really, really good about starting a throwing program. Again, I love the sock program. That's just a sanitary sock with, or tube grip with a baseball in it. Again, this is a Porterfield drill that I picked up, and I've used it for years and years. Love it. We do a lot for the core of the body. You know, I tell our therapists, our students all the time now that, you know, if you're laying on the table and doing exercises in rehab, you're freaking me out. You got to be on a stability ball. You got to be in a lunge. You got to be on a single leg stance. You got to engage your body. Even if you're doing full can, Dr. Job's full can exercises, you're not laying on the table. You're not standing there in a bad posture. You got to be toned up. You got to be ready to roll. Like this guy, NFL quarterback, big injuries, right? Why would I have him on the table? So he's in a high plank, bringing everything into it. Scapula, core, posterior chain. And you all know this. Plyometrics, I already said, delay with a purpose, watch your workload, excuse me. Last thing to mention, last couple minutes, is return to play criteria. For years, Dr. Andrews and I, and Dr. Dugas, Dr. Kane, we've talked about why don't we have a better return to throwing criteria? And so about 4 years ago, we started to develop this a little bit more stringently. This is a paper that just came out that in the International Journal of Sports PT, where we developed with others a neurocognitive testing protocol for upper extremity injuries. So not just for the thrower, but any upper extremity. We've learned the hard way with ACL patients that after an ACL injury, when someone can't recruit, can't turn their quads on, it's not that they're not trying. It's not that they forgot how to do it. It's not muscle re-ed. There's something that happened in their central nervous system that short-circuited. That's been well documented with ACLs, ankle sprains, and now some data is intriguing that's showing with recurrent shoulder instabilities that also happens. That what happens is you use different centers of your brain to recognize a position for one, and second is use abnormal recruitment patterns. So it's that ACL patient who just can't turn it on. So what do we do for throwers? Well, we obviously look at range of motion. We don't need to get into that. We rely on a clinical exam. That means trainer, therapist, MD, who's either evaluating them. And then we've done isokinetic testing. This is some work done years ago with the White Sox, where we did isokinetic testing. Nowadays, I use a handheld dynamometer. And I'm a ratio guy, ER/IR, torque to body weight. Look at some bilateral, but I look at obviously glenohumeral joint, but scapula and hip as well. And hip is critical, right? The other tests we do are called ball drops, and we've done these for several years. We're probably up to almost 500 of these tests on healthies and UCL. You can hit that. Sorry about that. So this is a ball drop test where the person just simply has a 2-pound ball in their hand. They lay on a table, unfortunately. I wish they were somewhere else. And they drop and catch the ball in 30 seconds. We count the number of catches. We compare it to the non-throwing side to non-throwing with 3 trials. We're looking for 90% or better. The next one is a wall throw, 2-pound ball again. They go as fast as hard as they can. There's a subjective component as well. Where is your arm slot? You can see he's leading with his elbow compared to that guy that I showed you before. So we look at mechanics, and I realize that's subjective. We go as fast and as hard as you can. We expect the throwing side to be about 110 to 115% more throws and catches in that 30 seconds. The other test we do is just back up and throw. You have to realize this is in a rehab environment. So they're 20 feet back. There's a target that's a 1-pound ball. 15 seconds, we're really just screening mechanics. And then one other test that Dr. Kibler has taught us is a single leg squat, which I always do with my young people. And no one hardly ever passes it, by the way. They usually stop. It's a 30-second test. There's a chair behind just in case they fall. And we look at the number of times, but we also video it to see if you're going into valgus, if you're flexing your trunk. But most young people obviously are weak in their hip. Last thing to mention in relationship to that paper, this year we were fortunate. We went to a lot of high schools and colleges. You may be familiar with the George Davies closed kinetic chain upper extremity test. So what we did is we basically used these light systems. So this is an NFL football player, sorry. And what he needs to do is stabilize, locate the target, and tap it. And we look at the ability to stabilize, the number of targets hit, and your reaction time from one target to the other. The other test that I really like the most is this one. Right hand is red light, left hand is blue light. He's got to stay in that up plank position, and he has to recruit. And we look at the number of touches one side to the other, or if there is a deficiency in the quadrant. We do similar testing with ACL patients. So it's the ability to dual task. It's the ability to centralize. It's the ability to stabilize and move dynamically with multiple functions. So let's do a test that's more specific for throwers, and we have a series. So that's a 2-pound ball, like I showed you before, 30-second test. The lights are mounted on the wall. There's distraction colors and target colors. And believe me, if you have someone do this with the distraction colors, it becomes taxing. The other thing you can ask them to do is count backwards, maybe by 7s from 100. That'll freak people out. But the ability, again, to process and react. And we'll do this with high school kids. That's a quarterback. And we also have a study going on right now with gymnasts. The data that we've talked about that's published in the paper, if you're interested, we looked at softball players, we looked at baseball players, we looked at high school and college, and we're eager to do this on the professional ranks as well.
That's the paper again. It's free journal. So you can just basically Google that and you can have at it for free of charge. So take home messages, just to wrap this up. Obviously, it's a team approach. We all know this in this room, the most communications you can have. Every one of those panels, the first thing I thought of was, I think I'm going to talk to the doctor first and see what their mindset is and formulate a game plan, as you all know. Monitor carefully. I think now with radar guns and video and all the analysis that's available, spin rates, it's fantastic. It's a wonderful world we live in. It's just going to get better. And obviously the take home message is don't rush it. You've got time. I want to thank Dr. Andrews and all of you for showing me the way. Thank you very much.
Kevin, thank you for a great talk and for all you've done over your career for our knowledge and for our athletes. You know, there's no question that good rehab makes us as physicians look better. So we appreciate it. We're about 5 minutes behind. I think we're going to try to shorten the break a bit to stay on time. So we'll see you all back here at 10:35. Thanks very much.